Good morning, everyone. I'm Ned Kwans, Chair of the Advisory Committee on Heritable Disorders in Newborns and Children, and I'm happy to welcome you all to the November Advisory Committee on Heritable Disorders in Newborns and Children. This is our November 2024 meeting and our final meeting for this year. I have some opening remarks, but first I'd like to turn things over to Letitia Manning for roll call and additional information on this FACA meeting. Letitia?
Thank you. Good morning, everyone. So I'm going to start with the roll call for the committee members. From the Agency for Healthcare Research and Quality, Robin Sagatov.
Present.
Michelle Kajana.
Good morning, here.
Ned Kalonge. From the
Here.
Centers, From the Centers for Disease Control and Prevention, Carla Cuthbert.
I'm here. Good morning.
Morning. Janine Cody. Christine Dorley.
Here.
From the Food and Drug Administration, Paula Capacino.
Here.
From the Health Resources and Services Administration, Jeff Brosco.
Here.
Ash Law.
Here.
From the National Institute of Health, Melissa Parisi.
Here.
And now I'll move to the organizational representatives. From the American Academy of Family Physicians, Robert Ostrander.
Here.
From the American Academy of Pediatrics, Deborah Friedenberg.
Here.
From the American College of Medical Genetics, Cindy Powell.
Here.
From the American College of Obstetricians and Gynecologists, Stephen Ralston. Or is there another delegate from, another representative from the American College of Obstetricians? No, okay. From the Association of Maternal and Child Health Programs, do we have an org rep? From the Association of Public Health Laboratories, Susan Tanksley.
Here.
From the Association of State and Territorial Health, Scott Schoen.
Here.
From the Association of Women's Health, Obstetric and Neonatal Nurses, Shakira Henderson.
Here. Good morning.
From the Child Neurology Society, Margie Ream.
Here.
From the Department of Defense, Jacob Hogue. From the Genetic Alliance, Natasha Bonham.
Good morning, here.
The March of Dimes, Siobhan Dolan.
Here.
From the National Society of Genetic Counselors, Amy Gaviglio.
Here, and happy Genetic Counselor Awareness Day to all who celebrate.
Thank you, Amy. And from the Society for Inherited Metabolic Disorders, Sue Berry.
Here. Nice to see you all.
Nice to see you too. Okay, so now I'm just going to move on to some general information about the Federal Advisory Committees. All committee meetings are open to the public. If the public wish to participate in the discussion, the procedures for doing so are published in the Federal Register and or are announced at the opening of the meeting. For the November meeting, we posted it in the Federal Register notice. We said that there would be a public comment period, and that public comment period will be after lunch today. Only with advance approval of the chair or DFO may public participants question committee members or other presenters. Public participants may submit written statements. We did not receive any, but that does not prohibit you from submitting a written statement. As a reminder, it is stated in FRN as well as the registration website that all written public comments are part of the official meeting record and are shared with committee members. And any further public participation will be solely at the discretion of the chair and the designated federal officer. As a reminder for ethics and conflict of interest, I'll remind all committee members that you must recuse yourself from participation in all matters likely to affect the financial interest of any organization with which you serve as an officer, director, trustee, or general partner unless you are also an employee of the organization or unless you have received a waiver from HHS authorizing you to participate. There is no vote scheduled for today. So just making sure all committee members are aware of that. And for our webinar instructions, members of the public, audio will come through your computer speakers. There's also a call-in option. For committee members and organizational representatives, audio will come through your computer. You can speak through your computer. If you need to call in using the phone line, you can do that also. Please speak clearly and remember to state your name to ensure proper recording for the committee transcripts and minutes. In order to facilitate discussion, please remember to raise your hand feature when wanting to make any comments during the committee discussion. If you're having technical difficulties, please email me and we will identify a workaround. And those are, you also have the closed caption option at the bottom of the Zoom, and that is for committee members and organizational representatives as well as the general public. And now I'm going to turn it back over to Ned. Oh, I'm sorry. I have one more announcement. Our 2025 Advisory Committee meeting schedule is already posted on our website. The next meeting will be February the 13th through the 14th. We also have meetings on May 9th, August 14th through the 15th, and November the 13th through the 14th. We will update the website with information regarding whether the meeting is in person or virtual. So please stay tuned. Okay, now I believe I'm turning it back over to Ned. Thank you.
Thanks, Letitia. And again, welcome everyone. I wanted to start out just taking an opportunity to acknowledge the devastation caused by Hurricane Helene and Hurricane Milton in our southeastern states. I know many of the state public health laboratories and other public health departments are continuing their recovery efforts. I personally, and on behalf of the committee, want to thank you all for your dedication and resilience and assuring all newborn babies continue to be screened in your states in order to receive timely diagnosis and care. You're in our thoughts, and we appreciate everything that you're doing to move forward. Can I have the slide on APHL, please? Just wanted to also provide a huge thanks, as well as congratulations to APHL for hosting a very successful newborn screening symposium in Omaha, Nebraska last month. While I was unable to attend, I heard the meeting was fantastic, with robust participation from various newborn screening stakeholders, including families and people with lived experience who have been directly impacted by state newborn screening programs. Their participation in meetings, conferences, and symposiums, as well as in other venues, is invaluable and provides all of us opportunities as well for other public health officials to directly engage with the populations that we serve. Thanks again, APHL, for providing the opportunity for this to happen. Can I have the next slide, please? In previous meetings, I think I made you aware of the National Academies of Sciences, Engineering, and Medicine's study examining the current landscape of newborn screening systems and processes. Over the past couple of months, NASEM has had several information gathering sessions from people who are impacted by and interested in newborn screening programs in the U.S., including families with children, the rare disease community, the public health professions, clinical care providers, healthcare administrators, and healthcare payers. The ACHDNC also shared information with the national academies to inform the study. The study has transitioned from that open information gathering into committee analysis and writing. After the committee generates the draft report, it will undergo a rigorous process that includes a review from a set of external reviewers. Using input from this panel of reviewers, the committee will finalize the report. I will tell you, having participated in those review sessions, this is more rigorous than peer review for journal publication. There's a lot of different reviewers who are able to provide expert guidance to inform the committee in the final product. The National Academy's plans to release the report in late August of next year. We will look to the National Academies in 2025 to share with the committee their findings. For more information, you can go to the webpage, which I think you can get to with the QR code. I don't know if I have a next slide or not. Okay, you just pause there. As you're aware, the committee has fully implemented a preliminary nomination process to ensure nominators have basic information required to complete a full information package. The process allows for the nomination and prioritization work group to provide timely information to the nominators prior to them completing the thorough full nomination package. In August, the committee received a preliminary nomination for Gaucher. And in September, the committee received a preliminary nomination for acid sphingomyelinase deficiency, or ASMD. I provided a letter to both nominators detailing the review from the committee's nomination and prioritization work group. And Letitia and I hope to meet with the nominators in the near future to answer questions and provide additional technical assistance. I also wanted to update you on the ACHDNC charter. Some of you may be aware the charter was set to expire this month. Committee's charter was approved by Health and Human Services last month, and with the same objectives and scope of activities as defined under the previous charter. We're all excited that the charter can continue to support the committee in its charge of advising the Secretary of HHS on aspects of newborn and childhood screening for heritable disorders. You can access the newly approved charter on the committee website on the quote about the committee unquote page at heritable disorders - about the committee line HRSA. The website, I believe, for ACHDNC is pretty easy to navigate. I always find it as a rich source of information that I'm trying to find. You might have recognized this slide from previous meetings. We updated this earlier in the last year and this year. The updates were to try to ensure that the matrix reflects how we're actually making decisions and have over the last 10 years or more. During the last meeting, we formally voted to adopt the revised decision matrix. And since that time, I've worked with HRSA and others to create definitions and descriptive language for the revised decision matrix. This information was included in your briefing book. And although we're not going to have a vote at this meeting, I encourage you to review these definitions and descriptions carefully. Provide us feedback as well, because this is what the ACHDNC will use to make recommendations to the Secretary on whether to recommend the addition of a condition to the RUSP. The descriptions and definitions will also be available on our website. Next slide. Amazingly, we're reaching our 20th anniversary, and the February 13th and 14th meeting will be our opportunity to recognize the anniversary. We're planning some special presentations to commemorate what we feel is a momentous occasion. And I'll ask you to keep your eye out for information regarding the meeting and our anniversary as it grows nearer. The next part of committee business is to recognize that our membership is, as it does, transitioning once again. And we would like to take a moment to recognize a couple of invaluable members of the committee who are rotating off. I'm going to start with Jennifer Kwan. Could I have the next slide, please? Jennifer couldn't be with us today, but I just wanted to say a few words in recognizing her service. We weren't able to properly thank Dr. Kwan and Shanika Pompercool for their service last meeting, but their term ended in July, and I wanted to just talk about what Jennifer did during her time with us. She joined the committee in January of 2022, and we made her hit the ground running. She served on the ACHDNC follow-up and treatment work group, the nomination and prioritization work group, and the evidence review group for CRAB-A. She was and is always extremely thoughtful in her responses and input, and her expertise in pediatric neurology was invaluable to us doing our work at the highest levels. We appreciate her dedication, appreciate the time she invested in this committee. I appreciate having a relationship with her where I could experience the breadth of her knowledge and her thoughtful input. And I want to recognize the impact she made on newborn screening. If you have opportunity in future meetings or in other settings, I hope you take the opportunity to thank Jennifer. Our second person rotating off in last July is Shanika Pompercool. And Shanika has joined us this morning. And Shanika, I wonder if I could just give you the opportunity to say a few words.
Well, thank you very much. It has been an honor to be part of this committee, and I wish the committee best of luck for many more conditions that we will continue. I learned a lot, and it's been really great. And thank you, everyone.
Thank you. I point out that Shanika also joined the committee in January of 2022. She served on the ACHDNC follow-up and treatment work group, and more recently served as a committee liaison to the evidence review group for metachromatic leukodystrophy and Duchenne's muscular dystrophy. She has extensive expertise in state newborn screening, endocrinology, and treatment of rare diseases in pediatric patients, and has been just a tremendous asset to the community we'll have a hard time replacing. Thanks so much for your service, Shanika.
You're welcome.
The August 2024 meeting summary was included in the materials. I want to thank the committee members and organizational reps for reviewing the summary and providing input for changes. There was one edit in the meeting summary, and Letitia sent the revised meeting summary, I think a couple days ago. I would ask, are there any other corrections to the meeting summary before we vote to approve? Seeing none, could I have a motion to approve?
I put forward the motion to approve.
Thanks, Ash. And could I have a second?
I'll second Janine Cody.
Thank you, Janine. I'll turn things over to Letitia for the roll call vote.
Sorry, Ned, I already did it. Sorry about that.
Oh, but so
For the roll call. Oh, I'm sorry. For
the vote, I'm sorry, yeah.
Yes, I'm sorry. Go back to that.
Just the members.
Noted. From the Agency for Healthcare Research and Quality, Robin Sagatov,
Yes.
Michelle Kajana,
I approve.
Ned Kalonge,
Yes,
Carla Cuthbert,
Yes, I approve.
Janine Cody,
I approve.
Christine Dorley,
Approve.
Paula Capacino,
Yes.
Jeff Brosco,
yes.
Ash Law,
Yes.
and Melissa Parisi.
Yes.
Thank you.
Thanks so much. The meeting notes are approved unanimously, and we'll move on. Just to remind you what we're doing today. The morning, we're going to begin with an overview of the Newborn Screening Information Center, Health Information Center. We're then going to transition to a panel presentation on research funding opportunities to document lived experience of patients and families. We'll take a break for lunch and resume with public comments. Then we'll have a project update on the family outcomes of the newborn screening project. And we'll get an update from the evidence review group on the metachromatic leukodystrophy evidence review. We're going to close the information and the meeting today with 2 additional presentations on laboratory developed tests and higher tiered testing. So I want to transition now to the presentation from the Newborn Screening Health Information Center. The Newborn Screening Saves Lives legislation requires HRSA to maintain a clearinghouse of newborn screening information. The Newborn Screening Information Center, or NBSIC, provides up-to-date information and resources about newborn screening to both parents and healthcare providers. To discuss and present today is Molly Lynch, who is the director of the Audience Engagement Research Program within RTI International's Communication Practice Area. She currently serves as the RTI Project Director for the HRSA-funded project for content development for the Newborn Screening Information Center. Molly has over 10 years of experience engaging families and healthcare providers to develop and evaluate newborn screening educational resources. And I would like to turn things over to you, Molly, and thanks for joining us.
Thank you so much. I'll get my presentation up here. Great, wonderful. Okay, well, good morning to everyone, and thank you so much for that introduction. Again, my name is Molly Lynch, and I'm with RTI International. We are a nonprofit research institute located in North Carolina, and we're the contractor, as we were introduced, who's currently managing the content for the Newborn Screening Information Center. So I'm very pleased to be here to provide an overview of the site this morning. Okay. Before I get into the site, I just wanted to take a moment to introduce the RTI team. We are a multidisciplinary team, and we're able to draw from several disciplines to ensure that we develop content for the site that is not only accurate, but also content that is engaging and resonates with the site's intended audiences, which is primarily parents and caregivers, as well as healthcare providers and other public health professionals. So you can see that we have a bench of newborn screening experts, including genetic counselors, who review all of our content, including the conditions pages regularly. And I'll show you those condition pages in a moment. But also we have a communication science team and a digital and content strategy team. And that's really to ensure that the web content is accessible and user-centered and follows a strategy to reach these audiences. Okay, so now on to the site. The Newborn Screening Information Center was launched in 2020 as part of the legislation from the Newborn Screening Saves Lives Reauthorization Act to maintain that clearinghouse of information about newborn screening. Previously, the clearinghouse was maintained on Baby's First Test, but the reauthorization of the legislation required the site to be hosted on the HRSA.gov site. And HRSA worked with the National Institute for Children's Health Quality and Expecting Health to build the information center starting in 2020. And then we were contracted by HRSA last fall, so we've been on this project about a year to maintain and develop new content for the site. And we are just very excited to work with HRSA on this project. Okay, so now without further ado, I will actually go to the site and give a brief tour. So let me navigate there. So the URL for the site is newbornscreening.hrsa.gov. I hope everybody will remember that and come back to the site frequently. But this is the homepage for the site, and it starts in this yellow box by giving an overview of what an intended user might find on the site. And then there are 6 tiles below that helps people navigate to important information about newborn screening. So I'll go through a few of these tiles and we'll check out kind of key aspects of the site. So these first 2 tiles are really more basic information about newborn screening and the newborn screening process. So I will click on this one here to take you to the newborn screening process page. This is, of course, a very critical piece of information that that new parents and expectant parents are looking for. This page is actually undergoing some transformations and enhancements, and that will roll out later this year. But currently the page is organized by some key questions here. When does newborn screening happen? Where does it happen? How does it happen? As well as some questions to ask and how newborn screening is different across each state and territory. So this is one long super page with a lot of important information. So I will go back to the homepage. Another key aspect is newborn screening in your state or territory. So this is another key aspect of the site. If we navigate here, you'll see an alphabetical listing of all state and territorial newborn screening programs. And I'll show you what each state's page looks like. I will select North Carolina because that's where I'm calling in from today. But each page follows a very similar structure here. So you can see at the top is the name of the state, and then begins an alphabetical listing of both the core and secondary conditions screened for in that state. And we are in contact with state newborn screening programs to make sure that this list stays up to date. At the bottom, you'll find the contacts and for the state newborn screening program, as well as the early hearing detection and intervention program, so that this information is accessible, as well as links to additional resources. So another key aspect of this site is you can see there are hyperlinks under each condition. So if you wanted to know more about a specific condition, such as cystic fibrosis, you would click here. And then this is another kind of really rich portion of the site where we provide a page for each condition. So this, as you can see, this is for cystic fibrosis. Again, each condition follows a similar structure. So you begin with the general condition information, where there's information about birth prevalence and the screening finding, as well as kind of the other names that the condition may go by. And then you, as you navigate down the page, there's a description of the condition, kind of background information, as well as getting into then more specific information about newborn screening and follow-up for that particular condition. So what does screening for cystic fibrosis look like? They talk about that. And then what happens if there's an out-of-range screening result? Under condition details, there's information here on the signs and symptoms, the cause, as well as inheritance and family concerns. And then the page wraps up with treatment and management information, as well as related resources that are really specific to that condition. I wanted to note, as I mentioned earlier, these are a set of pages that get reviewed quarterly by our team of genetic counselors to ensure that any clinical updates are reflected on a quarterly basis. The other aspect I wanted to show on this page is that if you click on this Espanol button up here, every page has the option of being translated into Spanish. And we have a Spanish content team that also reviews these. So this is not an AI translation. We have real people with genetic counselor backgrounds who are reviewing the pages in Spanish as well. You'll see that, and every page on the site is available in Spanish. Okay, I'll go back to English for the duration of the tour here. The next thing I wanted to show was that we do have a glossary. The site does have a glossary located right here at the top. And if you find, a term on here that may not be known to kind of a general audience, such as pancreatic enzymes, if you click on that, it will take you, and there's a plain language definition for all of these terms that may be sort of more medical or technical jargon available in plain language. And the glossary page, if you just want to peruse the glossary, is here, and it's in an alphabetical listing of all of these terms, but they are hyperlinked throughout the site so that anybody reading the site would be able to find a definition of that term. Okay. All right, I think I'll wrap up with the newborn screening for providers page here. So while the rest of the site is really meant for and accessible for parents, caregivers, and kind of anybody from the general public or professional audience. This page is specific to providers. We do intend to kind of build out this page a bit more this year. That is in the plans. But I did want to let everyone know about this page specifically within the site. And then there's a new resource that we've been working on over the last year that has just hot off the press and has just recently been posted. And it's the Communicating Out of Range Newborn Screening Results to Parents and Families. So this is really a guide specific to providers that they can use for those conversations that can be quite difficult and potentially emotional. And it's really a resource for providers to use in that context. So I'll just do a brief demo of this resource. So it is organized around what we call the 4 C's. So kind of a shorthand to remind providers of what the key aspects of communication around this topic area are. So clarity, compassion, continuity of care, and connection. And then within each of those C's, there are some kind of guidance about what the key information needs that parents might have at that time, as well as conversation starters for kind of each of these 4 buckets of information. We were able to test this with both healthcare providers and parents last year and reflected any feedback from them, so that this is a tested resource that we have made sure is resonates with healthcare providers who might be using this tool. So that is available now on the site. Okay, well, that's the overview, and I'll go back to the presentation now and just run through a few more slides about what we've done this year and what we hope to do in the next year. Okay, so our goals as the contractor for managing content on the site are really fourfold. The first is we really do want to continue to engage with state and territorial newborn screening programs, because that is so important to keep the site up to date and keep those state panels accurate with any conditions that may have been added or removed on a quarterly basis. Similarly, we also will continue to conduct expert review of those condition pages and add new condition pages as needed. We also use insights from website audiences, so parents and caregivers and healthcare providers, to develop new content and website enhancements that will really resonate with these audiences. And finally, we don't just want to create a resource that is out there without getting into the hands of people who really need this information. So we also have a goal to promote the site to parents, healthcare providers, and other key audiences. All right, I'll talk a little bit, as I mentioned, about what we did this past year to enhance the site, as well as plans for future enhancements. So one thing we worked on last year was to redesign the homepage. Previously, it had kind of 4 links to take you to key pieces of information. We've expanded that to 6 to include results and follow-up information, as well as the resources page. Just hearing from parents that those were really important pieces of information to be able to locate quite quickly. So we've done a bit of that homepage redesign, as you could see on the overview. Okay. As I mentioned, we do have a lot of communication science background on our project. So one of the key aspects we looked for was to make sure that when you go to a page, the main message is highlighted. That's just important for audiences to be able to take away that key information, even if they're just glancing at a page. So we have developed or highlighted main messages on each page to let that website user know what they are expected to learn or do on the page, or potentially a key takeaway message that they could remember after visiting the site. We've also added some visual enhancements. So we've added some photography to the site. Photographs and visuals are, of course, just help break up the text and make the site more engaging. So we worked to add those to these key pages last year. We also reorganized the resources page so that the more parent parent-centric resources came first. There's a long list of different types of resource pages on this page, and we wanted parents in particular, if they were, if they were looking for resources, that they could find those easily. So the support and advocacy organizations are now at the top of the page. As I mentioned and showed through the website, we also have this out-of-range communication guide for providers. And we're really excited that this is now posted and this is live. We've been at some conferences over the past month and kind of promoting this resource. So we're really excited that it is now available to the public. It will also be available in Spanish in the next month or so to be posted on the site. Okay, we also have some plans for future enhancements. These will be available in both English and Spanish. So there will be some new content on the road to the RUSP. So there'll be some text and visuals and graphics that really describe that process for adding conditions to the RUSP. So that will be coming later this year. We will also be adding some just additional parent-friendly newborn screening resources through web pages, infographics, and other content, so that the newborn screening process is really accessible to parents. They can kind of look at a visual representation that is also in plain language and easily understand the process. And then finally, as I mentioned, we will be enhancing the provider page. So we've added that new resource, but we're excited to kind of expand out that content a bit more and make that page really useful for providers. All right, and as I mentioned, we do want to promote the site to make sure this information gets into the hands of the people who need it. So we do submit abstracts, at least 3 per year, and recently we just presented at APHA, APHL, and the American Society of Human Genetics. So that happened in the past month. We will also continue to develop content partnerships. So what that means is really having a partnership with other key organizations in this community, such as state newborn screening program websites and other professional and advocacy organizations, so that we could link the Newborn Screening Information Center. So if audiences are on that site, they could see a description of what the NVSIC is and then link back to our site. And then we will also leverage some social media around key observances. So we ran kind of a pilot social media campaign for Newborn Screening Awareness Month in September and had some really nice results from that. So we will continue running social media ads throughout the year around some key observances. We will also implement some Google search ads. So those are paid ads that come up when somebody's searching about newborn screening, and that will go to the top and help direct people to the site. And then we do hope to have a larger, as I mentioned, it was sort of a pilot campaign this past September. So looking for just a bit more social media presence in the next September Newborn Screening Awareness Month. So I'll wrap up here, and I'd be happy to answer any questions about the site. This is a QR code to take you there. This is also the URL newbornscreening.hrsa.gov. And we hope you'll visit and peruse the site. So thank you so much.
Thank you, Molly. That was super. Well, we'll open the floor for discussion, starting with committee members and then moving on to our organizational reps. I did want to perhaps start with one is a recommendation that you probably already know, but as you think about promotion, I hope you think about promoting to those who would use the information to relay information back to patients and their families. I'm thinking specifically pediatricians, family physicians, OBGYNs, and advanced practice nurses who provide that care as well. So that, you know, all of those groups have annual meetings with scientific presentations and understanding this resource is out there. Even if you're not going to memorize the conditions, knowing where to go when something pops, when you get something that's positive would be quite useful. And my question is, when you say gather insight from different audiences, is that passive or active in terms of getting information to make the website better.
Yes, thank you so much for both of those points. I think we've been talking a bit internally with our HRSA colleagues about how to reach those providers. So we'll definitely be integrating that into our promotion plan for this year. And then, yes, thank you for the question about user insights. We actually had have a separate contract on that's around evaluating the site. And so through that contract, we are able to more directly engage with our intended audiences through usability interviews, where we recruit members of the audience and we have them look at the site, and we've been able to gather some really great insights from both parents and healthcare providers about what their information needs are and how we can best reflect that in the site.
Appreciate that. Thanks. Christine?
Thank you for a really good presentation, Ms. Lynch. My question or comment, I know that this body at some point has to make a decision regarding counting conditions because of the seemingly disparity between states, but in the interim, are there any plans to kind of minimize some of that confusion or this pseudo disparity that exists by perhaps separating out the target conditions or the core conditions from the secondary targets based on how states are indicating that? For instance, Maryland, we say we screen 62, and I noticed North Carolina has 60 disorders that they're screening for. Is there any kind of plan in the interim to try to help minimize some of that confusion?
What a great question. And this is definitely something that has been on our radar. We have conducted some listening sessions with state newborn screening programs last spring, and this definitely came up. So it is something that is definitely on our kind of just, we're definitely thinking about it in consultation with our HRSA colleagues. As I mentioned, we did some usability interview testing on the separate evaluation contract. And through that, we were actually able to test some different iterations of what the page could look like with core versus secondary conditions separated out. So we do have some data around that from what users would appreciate. I don't think we have any firm decision right now, but we are also extremely interested in following the guidance of this committee along with it. So it's definitely a big issue. We have it on the radar, but the plan is not final for how we'll address that, I would say, at this moment.
Thanks. Ash?
Thank you. So my comment is, I think just following up on Ned's comment that is there a link out or inclusion of treatment sites for rare disorders that are easily accessible to? Because that sometimes is one of the initial questions that comes up. Maybe even at the level of the primary care providers. So is that within the scope of this site to have an active listing, or maybe a link out is more appropriate? How do you think that should be approached?
And I'm sorry, I'm not sure I understand the question.
So for most of the rare disorders, there are a limited number of specialty treatment centers, especially for new therapies, like the gene therapies, for example. They may initially only be set up in a limited number of centers around the country. And every state may not have a designated center within the state, maybe in the neighboring state, or maybe something in the region. How is that information? That's what I wanted to ask. Is that information a part of the scope of this website, or can you provide a link to in your provider section to where that information can be found?
So that's a great suggestion. I don't think it's currently part of the scope, but this is wonderful feedback that we would definitely look into and discuss. It sounds like a very important set of resources to link out to on the provider page. So really appreciate that.
Thanks. Cindy?
Thank you. Hi, Cindy Powell, ACMG org rep. Thank you, Molly, for the presentation and great work on that website. I know you mentioned you're still developing the provider portion, but I did wonder if you'll be able to link to the ACMG act sheets that do give, some specific information about the disorders, both those on the RUSP and other rare diseases.
Yes, thank you, Cindy. That is definitely something also on our radar, and we'll be discussing with our HRSA colleagues, the best place to put those, and if they belong in the Newborn Screening Information Center, we can link to them specifically. So definitely something we're discussing. Thank you.
And Amy?
Yeah, thank you. Amy Gaviglio, org rep, NSGC, and I'm saying this as someone who's been involved in this work since it was really NICHQ who first worked on the site with Expecting Health Babies First Test as a subcontract, and then now with RTI. But I am getting a bit concerned about the diffusion and redundancy of some of the educational efforts, because I think it's becoming difficult for programs to know kind of where to send families and providers to. And I think particularly if I look at, obviously, I believe that the communication guide is very important, but it's very similar to a document we created with the education and training work group. And we worked hard to link that to the act sheets and share it with programs. And so I think as we create similar documents, we're going to have to really do an environmental scan of where those have been linked to. Do we continue to use the initial one that HRSA helped us develop, this new one? So I would just overarchingly encourage us to really understand what has already been done and what has been shown to be effective through evaluative measures, and how we may really need to think more kind of innovatively about different education and engagement opportunities, so we're not just kind of recreating things that we've done in the past. So that's just an overarching comment on education and newborn screening in general.
Yes, thank you so much, Amy. That is a very well said remark, and we'll always take that under consideration.
Well, thanks again, Molly, so much. It was a great presentation. The work looks engaging. I appreciate your receptivity to comments and cautions, and we look forward to the evolution of the website moving forward. Thanks so much. I'm really excited about moving to the next section, which is research funding opportunities to document lived experiences of patients and families. During the last couple of years, the committee has heard through public comments and other mechanisms of feedback varying experiences from parents, patients, and families impacted by the newborn screening conditions that are under review by the committee. The stories and the experiences that are shared with us have been powerful, and we're always grateful to all the families that have shared and who will continue to share. The ACHDNC Evidence Review Group and the committee are unable to use the information shared during public comments to impact our recommendation unless it's also included in research and in our research framework. So we've invited various federal agencies and a presenter from the private sector to share funding opportunities for research on rare diseases that could include and will include family and or lived experiences. Now, due to the number of panelists, I'm going to do a real brief introduction of all of the presenters. I don't want to in any way discount what is an extensive knowledge and experience base of each of the presenters that we're bringing to the table, and I want to thank them for presenting as well. In order, we're going to start with Dr. Mike Hugh, parent of 2 children with a rare genetic disorder. He is the co-founder and treasurer of Project Guardian, a nonprofit organization with the mission of advancing genomics-based newborn screening. Then Dr. Nora McGee is the associate director in the Clinical Comparative Effectiveness Research Program at the Patient-Centered Outcomes Research Institute, also known as PCORI. She is also the staff co-lead for the PCORI Rare Disease Advisory Panel. Our own Robin Sagatov, the ex officio for AHRQ, is the Senior Advisor for Children's Health in the Division of Priority Populations in the Office of Extramural Research, Education, and Priority Populations at the Agency for Healthcare Research and Quality, or AHRQ. Dr. Melissa Parisi, our own, is the Chief of Eunice Kennedy Shriver National Institute of Child Health and Human Development's Intellectual and Developmental Disabilities branch. She currently oversees NICHD's Eunice Kennedy Shriver Intellectual and Development Disabilities Research Center. And then wrapping us up will be Dr. Catherine Riley, Lead Health Scientist at the Centers for Disease Control and Prevention, where she currently leads a project focused on the use of large-scale electronic health record data to study rare conditions and emergency public health issues. Some years ago, Catherine served as the DFO for this very committee, and so we're thrilled to see her back. So given that, I'm going to start with Mike Yu.
Thanks, Dr. Colon. Thanks for the committee for inviting me to share with you. I didn't know I was going to be the first presenter, so alternative funding opportunities for newborn screening research. And as Dr. Colon mentioned, Project Guardian is a nonprofit. We focus on large-scale newborn sequencing research studies. So funding needs are high for us. We've certainly seen our fair share of fundraising challenges. So I hope this can be useful for anyone who's out there aspire to do newborn screening research in all kinds of capacities. Next slide, please. So the first one I'm going to tap into is a commercial funding. As most of you probably know, most pharmaceutical companies provide funding to the patient community in various forms, mostly through grants, and they support different causes. I have a screenshot for one of the companies here as an example. In this particular company, if you go into the company tab and then the giving program, you will see they have 4 different focus areas that the company is looking into. And they have a formal grant portal set up so you can submit your grant requests. And all of these have additional information, pretty self-explanatory, so you can get into that. And it's geared towards patient advocacy organizations, but individuals can certainly apply for it as well. Some smaller companies may not have such resources to establish grant channel. So in those, and you know, if your specific indication is being looked into by a company that is small, doesn't have that, I would suggest the first route to go is to find people in patient advocacy roles in those companies. You can either do a web contact search, or then LinkedIn search is actually very helpful. People in these roles are very connected to the patient community, and they are very responsive. So even if you reach out on LinkedIn as a cold message, they will most likely reply to you. I have certainly seen a lot of those myself. So I would encourage you to do that. And more importantly, I would say this is probably true for all of the other channels I'm going to talk about, but especially for commercial funding, it is important to identify an internal champion who can understand your cause, understand what you're trying to do, and can advocate for you on your behalf in their internal discussions and grant reviews and whatnot. So definitely try to do that. Next slide, please. The next channel I'm going to talk about is grants from larger pan-disease advocacy organizations, the likes of EverLife Foundation and Global Genes, which I put here. There are certainly others as well. And you can see in this example, for EverLife, this is from their website, they do provide tools and resources grants for survey capabilities and patient experience data collection efforts. This is certainly within the scope of what lived experiences is about. In addition to funding, they also have a lot of useful resources that might be helpful along the way. So I would certainly suggest reaching out to them, even if you are not looking for funding per se, but they will have experts who can provide some useful guidances and then most likely some useful resources for the particular research that you might be looking into. Next slide, please. The other big channel is philanthropic foundation grants. You've all probably heard about the likes of Gates Foundation or Sean Zuckerberg Initiative, which I put their grants page here as an example. They can certainly be a great resource, and I want to highlight that every foundation works a little bit different, and they all have their own focus areas. So here, some homework is certainly needed. You need to probably do a search and to find the one that matches your mission most closely. And then additionally, private foundations are typically flexible in terms of funding projects that may not even on their map. If you can find someone to talk to, you might understand better how that alignment can be established. And so it's a two-way conversation. Again, an internal champion would be very helpful here. So I will certainly suggest reaching out to some of the foundations that is related to the area that you want to focus in. Next slide, please. And specifically for lived experiences research, there are some additional opportunities out there. One is what probably every patient advocacy organization is familiar with, which is fundraising. In this case, I think some targeted fundraising efforts can certainly help. When we talk about lived experiences research, I think it can be in the forms of a case study. It can be in the forms of surveys and interviews. So in order to design those, if there's no readily available ones, you might need some professional guidance in the form of consultants. There might be some manuscript drafting. A medical writer might be helpful. And then at the end, there's journal publishing cost. All of those add together as typically not a huge cost, maybe in the range of 5 to 10 grand. So a targeted fundraising effort can be very helpful in addressing that gap. Another one, which is more hidden, I would really like to thank my colleagues, Amy Gaviglio and the National MPS Society for identifying these. This is something that we actually used before. Thesis work for programs such as genetic counselors and graduate programs in the areas such as bioethics, neurobehavior, and development. We've actually used this before in the MPS 2 nomination through researchers at University of Minnesota for a case report. And so in this case, it can drastically simplify your work because graduate students who need to do thesis work are motivated to work with you on everything that's related to the research. You just need to provide your lived experience and round up your disease community to do the same. And finally, doing it yourself is not, it's the last resort, but it's not as challenging as it might sound. I think, if you can read a few publications in this area, you get an idea of what writing a manuscript is about. If you can search for some surveys, design your own isn't that hard. It's always an option, but I do want to highlight that I thank the committee and HRSA for the effort looking into this area in trying to turn lived experiences into evidences that we can use in the review process. That's a great step. I do want to caution that I hope this becomes not just another hurdle for the nominators to jump through who already have a huge task of assembling the nomination package. So some systemic improvements for research in this area is needed. Good news is it's on the horizon. Jeff can tell you more about it if you need to, but there are research centers funded by HRSA that are looking into toolkit development and for connecting researchers with advocates. Next slide. Last, just as an example, the funding mix for our project is pretty much all of the above. If you want to know more, feel free to visit our website, and I'd be happy to talk to you more about it individually. Thank you for the opportunity to speak.
Thanks so much, Mike. I'm going to ask committee members and our org reps to hold your questions to the end. So hopefully you've written little notes, things you'd like to ask Mike. And with that, let's move on to Nora. Welcome, Nora.
Thank you so much. Good morning. Thank you for the opportunity to speak to you today about the Patient-Centered Outcomes Research Institute, PCORI, and our funding opportunities relevant to those working in the rare disease space. Next slide. So I'm going to spend a few minutes telling you about PCORI and our funding opportunities, as well as our rare disease portfolio. Next slide. First, a bit about PCORI. Next slide. PCORI is an independent, nonprofit research organization that seeks to empower patients and others with actionable information about their health and healthcare choices. We fund comparative clinical effectiveness research, or CER, which compares 2 or more medical treatments, services, or health practices. The findings from these studies help patients and other stakeholders make better informed decisions. Next slide. So some key features of our funded research and research-related projects. We engage patients and other stakeholders throughout the research process, and we expect our awardees to do so as well. We're committed to ensuring that they have a seat at the table throughout the life cycle of the award, helping to prioritize research topics, design and conduct the studies, and share the results. As I said, we fund comparative clinical effectiveness research, CER, and the comparators for our research must have evidence of efficacy or use. Our funded work focuses on answering questions most important to patients and those who care for them. We believe patients deserve to know whether some approaches work better than others for certain populations, and caregivers, clinicians, and all of our stakeholders benefit from having better information about different care options. And finally, our funded work aims to produce evidence that can be applied in real-world practice settings, which is often not a focus within health care research. Next slide. We have been requiring engagement in our studies for over 10 years now, and we have found that true engagement makes meaningful differences, as it influences study conceptualization, execution, and materials, as well as the way study tasks are carried out, how engagement itself is designed and practiced, and researchers' understanding of the needs of people and organizations. Engagement not only benefits patients, whose care may ultimately improve based on study findings, it also benefits research teams. And one way is by helping them refine their research questions, thus enhancing the relevance of their results. Next slide. We have recently developed new foundational expectations for engagement that I urge you to read through on our website. These lay out the requirements and provide guidance for engaging patients and other important stakeholders during each stage of the research process. We also have a wealth of other resources there, some of them developed as part of PCORI awards, that I think you will find helpful. Some of the resources include information on measuring what matters, guidance on building effective multi-stakeholder research teams, and a research fundamentals course that is very helpful for research partners. And this course is also available in Spanish. Next slide. At the core of what we do at PCORI are our 5 national priorities for health. These are ambitious, long-term goals that will guide PCORI's funding of patient-centered CER and other initiatives related to engagement, dissemination and implementation, and research infrastructure. I won't read through them, but you can find them on the right-hand side here. Next slide. PCORI has an interest in research across a range of areas, but we have a particular focus on the topic themes of interest that will inform focused funding opportunities over the next several funding cycles. We have had a long-standing legislatively mandated rare disease advisory panel that has affirmed our interest in work on rare diseases. And our board has amplified that by confirming addressing rare diseases as a topic theme of interest, as you can see here. Next slide. So now I want to give you a sense of the types of PCORI funding opportunities available, any of which might be a possible avenue for work in rare diseases. Next slide. So here you can see descriptions of the research funding announcements we will be offering in 2025. Most of these announcements are offered 3 times each year. The first is our Broad Pragmatic Studies, or BPS, funding opportunity. This opportunity seeks applications on investigator-initiated topics, which include rare disease. The funding announcement allows 3 types of award, which can go up to $12 million in direct costs and last up to 5 years. The second type is our methods funding announcement, which supports work that will ultimately improve the design and conduct of CER. The next is our science of engagement. This is a multi-year effort to build an actionable evidence base that clearly identifies the methods and approaches that lead to effective engagement in research. Next are our topical announcements. These are focused on specific high-impact topics aligned to our topic themes, with the aim to produce evidence that will have a substantial impact on practice and patient outcomes. A recent topical funding announcement was focused on rare diseases, and we expect to make awards for this in the spring. The next is our PLACER, the Phased Large Awards for Comparative Effectiveness Research announcement. This supports large-scale, high-impact randomized trials in CER whose risk in achieving their research aims merits an initial period of testing and refinement to determine their feasibility and viability and maximize the likelihood of full-scale trial success. These can last up to 6.5 years total and can be up to $22 million in direct costs. I encourage you to visit PCORI.org to review the detailed funding announcements. We also have a dissemination and implementation awards program that I won't have time to describe today. Next slide. Here you can see information about the different competitive engagement funding opportunities we offer. The 2024 deadlines have passed and the 2025 ones have not yet been released, but we do expect them to be in the spring and fall. Most of our engagement awards fall under capacity building. They provide an opportunity for organizations and community groups to build capacity and skills for CER. The dissemination initiative supports organizations and community groups that have established relationships with end users to disseminate the findings from PCORI-funded studies. They can disseminate the PCORI study alone or as part of a body of evidence that's relevant. The Convening Support Program provides funding for stakeholders to explore critical issues related to CER. The awardees may also communicate PCORI-funded research findings to end users. Next slide. So now I want to spend a few moments giving you a sense of PCORI's varied rare disease portfolio. Next slide. We have funded 41 rare disease studies for a combined total of $120 million in research funding. We have also funded over 60 rare disease engagement studies. Next slide. You can see here that our rare disease research awards are across a large number of different conditions, most of which you'll see listed here on the right. Several of the awards are cross-cutting rather than focusing solely on one disease. These look at patient and provider education, care delivery, and care transitions. Next slide. I'll just leave you with some more information about how you might get involved with PCORI or keep up with our work. Next slide. There are many ways to get involved. You can apply to serve on our advisory panels, become a merit reviewer to review our research applications that are submitted, become an ambassador to spread the word about PCORI, or become a peer reviewer who looks at our research findings at the end of our studies. We need scientists, healthcare stakeholders, as well as patients to get involved in all these important activities we do. Next slide. Here's a list of our advisory panels. As I said, we have one focused on rare diseases that you'll see listed at the bottom. Next slide. I encourage you to check out our website for more information on anything I mentioned today and sign up to get our weekly newsletters to keep current on what we have going on. Next slide. Here are some general links to find out more information about the funding opportunities I mentioned, and you can always submit a request to our help desk if you'd like more information. We have a lot of additional resources on our website related to conducting research as well as engagement that I encourage you to check out. Next slide. Thanks again for the opportunity, and I'm happy to answer questions during the discussion portion.
Thanks so much, Nora. I appreciate the information. And we're going to move on to Robin.
Good morning, everyone. Can you hear me okay?
Yes.
Okay, great. Hi, my name is Robin Sagatov. I'm the Senior Advisor for Children's Health in the Office of Extramural Research, Education, and Priority Populations at the Agency for Healthcare Research and Quality, or AHRQ. I'm going to share some information with you about AHRQ and our funding opportunities. Next slide, please. Thank you. So to provide some background about AHRQ, we are the lead federal agency charged with improving safety and quality of healthcare for all Americans. And to do this, AHRQ develops the knowledge, tools, and data needed to improve the healthcare system, and help consumers, healthcare professionals, and policymakers to make informed decisions. And our mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work with the Department of Health and Human Services and other partners to ensure that the evidence is understood and used. Next slide, please. So there's a link at the bottom of this slide to a site that has more details about AHRQ's research priorities. At a very high level, AHRQ's research priorities are research to improve healthcare quality and patient safety, improve healthcare delivery and practice improvement, and enhance whole person healthcare delivery. Next slide. So at AHRQ, we have training and career development grants like the R36, K01, and K08 awards. We have health services research grants, including R03 small research grants, R01s for large research grants, U18 cooperative agreements, and large demonstration, dissemination, and implementation R18 grants. And then we also have R13s, which are conference grants. Next slide. If you scan this QR code, this will take you to AHRQ's website where you can learn more about our grant funding mechanisms, due dates, open notices of funding opportunity, and you can also sign up to be notified about new funding opportunities on that page. Next slide. And this QR code will take you to a page on AHRQ's website with all of the current notices of funding opportunities. Rather than reviewing each of them with you, I prepared a couple of slides with examples of awarded research grants with topics that would be of interest to this group, such as studies related to newborn screening, child screening, and children with rare diseases and/or medical complexity. Next slide. So the first example is an R01 submitted by Dr. Lisa Prosser at University of Michigan, Ann Arbor. This aimed to provide the necessary information needed for policy decisions regarding selection of conditions for newborn screening panels. And the study looked at health and economic outcomes for newborn screening using computer modeling, systematic reviews, expert opinions, surveys, and stakeholder engagement, and focused on the evidence gap identified by this group. Next slide. Next is an example R01 by Dr. Anna Kerr at Ohio University, Athens. And this study related to primary care needs for patients with vascular anomalies and aimed to improve continuity of care and care coordination for rare diseases. And they were really looking at, amongst the specialists for vascular anomalies, caregivers, and pediatricians, what the facilitators and barriers to care coordination for patients with vascular anomalies were. Next slide. As an example, K Award, this K01 by Dr. Kendra Liljenquist at Seattle Children's Hospital had a goal to improve developmental assessment in primary care settings through specification of a computer adaptive developmental assessment that could be used by parents, clinicians, and community health workers. Next slide. Next is a K08. This was a grant by Dr. R.T. Desai that aim to improve the quality of care coordination for children with medical complexity. And this included participatory iterative design approach to a web-based care plan designed to meet families' needs. Next slide. So this slide includes some links to additional examples of awarded grants that you can review to get a sense of the types of grants that ARC has funded previously. I don't have time to go into them in detail, but feel free to take a screenshot and look into these in more detail. And I'm happy to chat offline about any of them. Next slide. Another way that ARC does research is through our evidence-based practice center, and we complete various types of literature reviews with this center, and we do accept suggestions for topics for evidence reviews. So there's a link on this slide where you can learn more about that. Next slide, please. This is just an example of a comparative effectiveness of treatment for PKU that was done through our evidence-based practice center. I know I'm running low on time, so I'm not going to go into more detail about that. Next slide, please. And finally, these are our notices of funding opportunity that are specific to patient-centered outcome research. These are 2K awards, and they're research mentored career development awards. Next slide, please. So thank you again for the opportunity to present about ARC's funding opportunities. My contact information is included on this slide, and I'm happy to answer questions during the discussion, or you're welcome to contact me if you have questions or research ideas. Thanks so much.
Thanks, Robin. Now we're going to turn to Melissa.
Good morning. Thank you for giving me the opportunity to speak with you all today. So as you probably know, there are 27 institutes and centers at NIH. And so I don't have the opportunity to tell you about all of the research being done, but I wanted to focus on some newborn screening programs, and particularly those that actually address some of the lived experience of patients and families. Next slide, please. And I'm sure this audience is quite familiar with the Newborn Screening Saves Lives Act, which established the Hunter Kelly Newborn Screening Research Program at NICHD. This is named after Hunter Kelly, who was the son of Hall of Fame football quarterback Jim Kelly of the Buffalo Bills, and he died of Krabbe disease. So this important legislation also specified the roles of various federal partners in the newborn screening landscape. NIH's role is to fund research, and we have 4 main components to our Hunter Kelly Newborn Screening Research Program: to develop new screening technologies, to develop novel treatments, to provide research findings that will help support conditions under review to be added to the RUSP, and to conduct pilot studies to ensure conditions are ready for nationwide implementation. And we use both dedicated grants and contracts to help support our research efforts across NICHD. Next slide, please. So innovative screening approaches are one of the types of funding opportunities that we support at NICHD. And we have 2 main categories: the integrative screening approaches and therapies for screenable disorders. This basically is for potentially fatal or disabling conditions that have been identified through newborn screening, or high priority conditions that have the potential to be identified through newborn screening. And you'll notice that these 3 funding opportunities have recently expired, but the R01, which is 5-year awards, and the R21, which is 2-year awards, are in the process of being reissued. And I would point out that one of the potential research objectives for a project responding to one of these PARs is to include embedded studies that explore the ELSI-related issues of novel screening technologies or therapeutic approaches. So we try to build in patient feedback into many of our initiatives, and many of those who respond to these funding opportunities do include that element. And then secondly, we also have another funding opportunity, a natural history of disorders screenable in the newborn period, which was just reissued about a week ago. And this encourages applications that propose to develop studies that will lead to a broader history of the natural history of conditions that are already on the newborn screening panel or have the potential to be added. Next slide. So we also support contracts for, I think we're a little bit further ahead than we need to be. Can you go back? Okay, thank you. We support contracts that are large-scale statewide pilot efforts for conditions that are recently nominated for the RUSP or have recently been added to the RUSP. And basically we have a pool currently of 3 states that have the capacity to screen at least 100,000 newborns within a 2-year period, and basically demonstrate the proof of concept for these new conditions and potentially new technologies. We anticipate that the contractor pool will be recompeted in 2027. Next slide. And this is basically illustrates over the past 10 years the different conditions and pilot studies that have been supported under this contract mechanism and the state or states that have successfully conducted those pilot studies. Currently, the congenital cytomegalovirus study is being pursued at New York by HRI, and they also have a follow-up arm to determine the outcomes for those babies that screen positive that is ongoing. And just recently, as of 2 months ago in late September, we awarded an award to New York also to study metachromatic leukodystrophy in a piloted manner. Next slide. So those are sort of an overview of what we do at NICHD. I want to pivot and tell you a little bit about our colleagues at NCATS. NCATS is the National Center for Advancing Translational Sciences, and they support the Rare Diseases Clinical Research Network, also known as the RDCRN. This was established in 2002 under legislation and currently supports 20 different consortia across 10 different NIH institutes and centers, of which NICHD is one. These are currently in the process of being recompeted. In fact, the reviews will be commencing very, very soon for the submitted proposals. And NICHD, in its list of preferred activities and high priority areas under this RFA, basically emphasized and highlighted newborn screening and newborn screening conditions as one of our areas of interest. Each of the consortia, very importantly, needs to study 3 or more rare diseases, have multiple sites, conduct 2 to 4 clinical studies, including a natural history or longitudinal study, have a pilot study program, as well as a career enhancement program to train the next generation of investigators. But very importantly, have a fully integrated patient advocacy group as part of the consortium. And these are not just lip service. The PAGs, as they are known, the patient advocacy groups, are integral parts of these awards, and they are absolutely essential for the success of these projects. Next slide. This is a list of all of the different consortia that have been funded, and I don't expect you to read all of these, but I highlighted in yellow those that are either related to newborn screening conditions or are conditions that have the potential to be screened in the future. And you'll notice that on the right side, there's a list of all those that have been funded under the past 4 cycles of the RDCRN. In 2018, it was decided that these were going to be sunsetted after having received at least 3 cycles of funding. So the top 11 consortia are no longer going to be able to compete in this next round, and we anticipate that we will be awarding a large number of new rare disease consortia, and we hope that some of them will also involve rare diseases that are related to newborn screening. Next slide. And then finally, the success of this program is multifold, but it has really had a significant translational impact. Many clinical trials, early phase clinical trials, have been supported directly by these cooperative agreements, and there have been many associated clinical trials that have been supported by industry partners or foundations or other groups, much akin to what Dr. Hu was describing earlier on today. And the results of these trials is that there have been 12 FDA-approved treatments for 11 rare diseases over the past several years. Next slide. So now I'm going to pivot and tell you a little bit about our colleagues at NHGRI and some of their programs. I know we've talked about ELSI before, and I've mentioned the acronym before, and I think most of you are aware that ELSI stands for Ethical, Legal, and Social Implications, specifically in relationship to genetic and genomic research. And that's really what NHGRI, the National Human Genome Research Institute, has embraced with regard to its emphasis on promoting understanding of really, what are the real world implications of funding research in genetics and genomics? So ELSI research is multidisciplinary. They fund a number of different, again, PARs, program announcements related to different bread and butter mechanisms that are utilized across NIH. And then they also have a relatively new program to advanced ELSI research that includes partnerships with relevant communities affected by and with an interest in the proposed research. So these are, again, cooperative agreements that involve considerable input from the family and patient community. And so this new program is called the BBEAR program, Building Partnerships and Broadening Perspectives to Advance ELSI Research. And I can tell you that over the years, NHGRI has supported a fair amount of research related to newborn screening conditions. Next slide. And one of the other major endeavors that NHGRI has pursued is something known as the Clinical Genome Resource, or ClinGen. This is an NIH-funded project that's dedicated to building an authoritative central resource that defines the clinical relevance of genes and variants for use in precision medicine and research. The goal is to really understand which genes and variants are associated with disease and how genomic information can inform clinical care. If you look at the upper left of this particular slide, you'll see a little circle for patients. And essentially, that leads us to the discussion of how these different components, patients, clinicians, laboratories, and researchers, can all input data that can inform the determination of whether or not a variant in gene is pathogenic. So next slide, a component of ClinGen is actually Genome Connect, which is the ClinGen patient registry. And this is really developed because ClinGen felt strongly that patients could serve as a very important source of additional information to inform the curation of genes and variants. So in 2014, they launched this patient registry called Genome Connect, and essentially it's open to anyone who has a genetic testing result, whether or not they have a diagnosis. They can input their data. So essentially participants enroll online, consent to de-identified data sharing and recontact, provide their health history through patient surveys, and upload a copy of their genetic test results. In addition, they can potentially receive genetic testing updates with regard to the pathogenicity of their variant or variants, and they can also connect with other families and patients who may have similar gene variants that cause disease through matchmaker exchange. So this is another very powerful tool that really engages patients in helping with the research endeavor. Final slide. Next slide. Well, essentially, it's my thank you slide. So that closes for me, and I want to thank you for your attention. I'm happy to take questions.
Thanks, Melissa. And finally, Catherine.
Hi, good morning, and thank you to the committee for the invitation to participate on this panel. It is very nice to be back with the committee today. We were asked to share with you the type of work we support in the space of lived experience of individuals living with inherited and rare conditions. Today, I'll focus primarily on the qualitative research we support, but first I wanted to share a couple of other ways we include the experiences of individuals, families, and communities in our work. Next slide, please. So first, I want to touch on how we gather and share stories of individuals living with the conditions that we study, as well as stories from their families and caregivers. Next slide, please. It's important for us to learn from the stories and experiences of the individuals living with the conditions we study in the National Center on Birth Defects and Developmental Disabilities. We do this in a number of ways. We have written stories from the individual and family perspective on our website. You can see a few of those stories depicted here on the slide for sickle cell disease and thalassemia. We work with individuals and families and the community to make videos to share on our website and across social media platforms. You see a couple of examples of those here on the slide as well. And our colleagues in the molecular branch of NCEH also have a webpage where they share stories related to individuals with conditions identified through newborn screening, also depicted here on the slide. So it is important to share these stories broadly, but it is also important that as we gather these stories, we are learning from these shared experiences and incorporating that knowledge as we plan and share our work moving forward and shape our work moving forward. Next slide, please. So next, I just wanted to highlight how we engage with community partners to both inform our work and help us collectively disseminate information and findings. Next slide, please. The sickle cell data collection program is a public health surveillance system that collects health information about people with sickle cell disease to study long-term trends in diagnosis, treatment, and healthcare access for people with sickle cell disease in the US. Each SCDC site has a multidisciplinary advisory team that includes healthcare providers, researchers, community-based organizations, people living with sickle cell disease and their caregivers, public health practitioners, and policy decision makers. The SCDC program developed a community outreach work group to bridge the data to translation gap between the community-based organizations and scientists to improve the lives of people with sickle cell disease. What they learned in this process is highlighted here on the slide, and this ranged from the importance of prioritizing trust building to fostering open communication to incorporating community voices from the very beginning. Next slide, please. In 2009, various organizations across the federal, state, and local communities came together and agreed that they could positively impact the health of those affected by congenital heart defects by utilizing a public health approach to address many of these issues that the community faces. So we supported the American Academy of Pediatrics to develop the formation of the Congenital Heart Public Health Consortium, comprised of organizational members representing voices of providers, patients, families, clinicians, and researchers. And you can see more about the organization on this slide and also online, and this organization is still growing strong today. Next slide, please. We also incorporate the experiences of individuals living with the conditions we study by building that engagement into the work through inclusion on advisory boards and strategic planning efforts. So on the slide here are just two examples of projects the National Center on Birth Defects and Developmental Disabilities currently is funding that have built-in community inclusion across the funded activities. Next slide, please. And although we do not have any current open notice of funding opportunities that focus on the lived experience, we do have many ongoing efforts that include this type of work. So I want to share a few examples of qualitative studies our center either previously funded or is currently funding that help us understand more about the lived experience of the populations we study and can contribute to the overarching knowledge base. Next slide, please. This year, we worked on efforts to reach Hispanic Latina women aged 24 to 35. The theme this year for Hispanic Heritage Month was A Mother's Love, Roots of Life with Folic Acid. These efforts were informed by formative research with the target audience, where we learned about knowledge, attitudes, and practices around folic acid and fortified food consumption. Preliminary findings helped guide the outreach to educate Hispanic and Latina women and their support networks about the importance of taking folic acid to help prevent neural tube defects. One outcome was the development of these videos, tips from Abuela's Kitchen, as depicted here on the slide. These were short videos in English and Spanish that focused on incorporating folic acid into traditional dishes while incorporating culturally relevant elements. Next slide, please. We also collaborated with the American Academy of Pediatrics to conduct focus groups to understand more about the challenges and barriers experienced by the Latino population living with spina bifida. The focus groups were conducted with a total of 28 participants earlier this year by Zoom in English or Spanish based on preferences. A big thank you to the AAP Birth Defects and Infants Disorders teams for sharing this information. Next slide, please. The goal of the study was to better understand the healthcare experiences of Latinos with spina bifida and their family members in accessing care, identify existing gaps in care, and gain a better understanding of any cultural and linguistic barriers that may exist. Next slide, please. 5 themes emerged, which are listed here on the slide. In interest of time, I'll just share some excerpts from 2 of the focus areas. Next slide, please. Participants expressed frustration with barriers they encountered in accessing essential healthcare services. So for individuals with spina bifida, the main issues were insurance coverage limitations, the financial burden of medical expenses, as well as challenges accessing doctors and specialists. And similarly, parents and caregivers shared about their challenge in securing specialized treatments and support for their children. They discussed the emotional and financial toll of managing their child's medical needs. Next slide, please. Transitioning from pediatric to adult care presents significant challenges for individuals with spina bifida, and I think this goes for many conditions, so many complex medical conditions that we all work on. Participants highlighted issues such as discontinuity of care, the difficulty in finding adult care specialists, and adapting to new healthcare providers, and the lack of mental health support for navigating these transitions effectively. Next slide, please. Here are just a couple of examples of focus groups or discussion groups that we're currently supporting through cooperative agreements with the American Academy of Pediatrics and Oak Ridge Associated Universities. AAP is conducting focus groups with parents and caregivers of children with birth defects and infant disorders to inform the development of strategies, resources, and technical assistance for clinicians and families. And ORAU is implementing discussion groups with peer support workers and pregnant and postpartum participants to learn more about knowledge, attitudes, beliefs, behaviors, and training needs. Next slide, please. We're also currently conducting focus groups, about 40, up to 40 focus groups across multiple conditions, including congenital heart defects, muscular dystrophies, and spina bifida. We hope that these focus groups will help us fill critical knowledge gaps, shape interventions, allocate resources, and inform clinical care. Next slide, please. So you can see here for congenital heart defect focus groups, we'll be focusing on adults that have been out of care for more than 3 years. And for muscular dystrophy focus groups, we'll be focusing on both adults living with several types of muscular dystrophy, as well as caregivers of children with early onset types of muscular dystrophy. And we hope that we can explore sources of clinical care, barriers to accessing care, the journey to diagnosis, and transition from pediatric to adult care. Next slide. And this is my last slide, and this is just to highlight the focus groups that we're doing as part of that larger effort for spina bifida. And again, these are funded under a contract with KRC Research. And the spina bifida focus groups will be doing up to 9 of those are going to be with adults living with spina bifida and also caregivers of children, and then focus groups, caregivers of adults with spina bifida. And next slide. So the work I shared with you today expands beyond the conditions that the committee may be focused on. However, I think we can learn across these complex medical conditions and apply what we learn from all the experiences across populations that we serve and learn how to better incorporate the lived experiences into all aspects of our work. Thank you.
Thanks so much. And thanks to all our speakers. And we'll move into a question and answer session, discussion session. I will prioritize committee members first, and then our org rep second. Appreciate input from all. I do want to point out that the slides went by quickly because we gave our wonderful speakers short periods of time, and they will all be available on our website soon after the meeting. So I appreciate that. And I might start with a question for Nora, if I might. I'm intrigued by thinking about CER for rare diseases where comparative effectiveness studies require having lots of subjects, and newborn screening detects very rare conditions. And so I was trying to get an idea of how that interplays, especially with your rare disease advisory committee. And would something like a study that looked at usual care or usual time of diagnosis compared with birth detected diagnosis fit under the rubric of a comparative effectiveness study?
Sure, happy to tackle that. So we have a lot of studies in our portfolio with usual care as one of the comparators. We are open to that as a reasonable comparator. We do have a methodology standard around the requirements for usual care related to that it has to be adequately described and measured throughout the course of the study so that it's not kind of an amorphous comparator, so that it can be a reasonable comparator for the study. As far as the feasibility in general of doing rare disease CER, it can be a challenge, and our advisory panel has been informing our work. And as I said, we had a recent funding announcement that we hope to put out some announcements soon for that. I think we are encouraging cross-cutting work where there are research questions that cross multiple rare diseases to help get around the small numbers problem. And I think we do have a number of studies, as I said, over 40 studies that focus on rare diseases, and most of them are pretty focused on specific rare diseases. So it's really a question of kind of what the right research question is, and if you expect a large enough difference between the comparators that you could get away with a relatively small number in your sample size.
Just a quick follow-up. I really appreciate that answer. It's very helpful. One of the things I've always appreciated about PCORI is that patient-centered. So you look at patient-centered health outcomes, and we're thinking about how to actually also capture kind of family-centric health outcomes. So when the actual involved patient is one consideration, but the impact of the family on comparative methods of detection or comparative therapies might also be really important. Does that fit within the conceptual framework for PCORI work?
Oh, yeah, of course. I mean, just because we're named the Patient-Centered Outcomes Research Institute doesn't mean we are narrowly focused on the patient only. It's really the patient. It lives within the family and within the larger, care ecosystem of their caregivers and also their clinical team. So it's really, as I said, we really emphasize engagement of the right players in developing the research question and the research plan, and that should involve patients, caregivers, and kind of all the relevant stakeholders. And they should be shaping which outcomes are chosen for the research study. And those could include patient-reported outcomes, patient clinical outcomes, but also family outcomes. It's really what's most important to answer that research question, and that it will provide the most useful research findings at the end of the study.
Thanks, Nora. That's a great answer. I really appreciate it. Let's see. First up, I have Bob.
Thank you. I'm surprised they didn't have any members ahead of me. I have a little concern listening to all these, and this isn't focused on any one person. I think it's hugely important that we have, patient advisory boards on these various projects and research panels for all sorts of reasons. But I don't know that having an advisory board constitutes lived experience research. I'm concerned about the selection bias problem, and I'm sure that's really been the challenge in my mind about this lived experience research. People who come forward with their stories, are leaders in their advocacy groups, may not really represent the population that we want to research the lived experience on. And I imagine it's incredibly difficult to get a good sample to do lived experience research. I mean, some of the focus group work that we heard about in the last talk with Catherine, sort of reaches that. I was involved in a journey mapping project with SCID at one point, but I'd be interested to hear, aside from including the patients, the advisory groups in study design for, more standard research, how we deal with the selection bias in doing real lived experience research.
I assume you're throwing that open for any of our experts who would like to answer.
Yeah, again, it wasn't any one thing. I mean, all the talks, there was a lot of talk about including patients on the advisory boards to make sure that the right questions got asked during the research, but then actually doing the research of the lived experiences and getting a broad representative sample of patients either with the condition or, our struggle all the time with this panel has been of the patients who are screened and get the false positives, plus the ones who are screened, and et cetera, et cetera. But even if you go just to the treatment limb, how do we get a representative sample for lived experience as opposed to just those who volunteer to be on the advisory boards, our leadership in the advocacy panels, and all that? Again, it's not to negate the value. It's critical that you have patient advisory boards on these study designs, so you ask the questions about things that are important to patients. But it's not the same as doing real research about lived experiences where you need a legitimate sample size and you want to avoid selection bias.
Thanks, Bob. Melissa?
Bob, I don't know if I can answer your question about completely avoiding selection bias, because I think that's very, very challenging unless you sample the entire constellation of folks with lived experience. I mean, obviously there's a lot of variability. I will say that one of the strategies that I think has been more effective is engaging families and individuals earlier on in the process. So prior to developing the study design, there was a a very illustrative example that I learned quite a bit from with one of the rare disease consortia that proposed to do a change to the dietary intervention for a given rare disease. And the problem was that they had not actually gotten buy-in from families. Families, even if that treatment was not really demonstrated to make a huge difference in the outcomes of their kids with this rare, devastating neurologic condition, felt like it was the one thing they could do. So asking them to go off this particular dietary intervention, even for a couple weeks, and switch to something else was just a non-starter. So if they had actually engaged those families and those patient advocacy groups before even designing the study, I think the chances that they would have stumbled into a failed project, to be honest with you, that just never actually hit its recruitment goals, would have been alleviated somewhat. So I think involving individuals as co-researchers, that means they're part of your team, and you may even need to compensate them for their participation, is actually one of the strategies that can be used. You still may not address all of those issues of bias, but it's one approach that may be somewhat successful.
Thanks, Melissa. Catherine?
Yeah, thank you, Bob. I think, and what I was trying to highlight in the presentation was that there are multiple ways we can be inclusive along the way. So similar to what Melissa had indicated. And I think for the research component, doing the qualitative research, so whether that be focus group or key informed interviews, or maybe a phenomenological study about the lived experience for a particular condition, I think those are also really important. So it's not that they're all the same, it's just different ways we can incorporate the community, the individuals and their experiences in the whole process. But certainly I think the research component and then being able to publish those results so they become part of the broader knowledge base that we can then collectively draw on is important. And so for many of the focus group and key informed interview projects that I mentioned, the goal is to then publish the results of those, that becomes part of the knowledge base.
Thanks, Catherine. Mike?
Thanks, Rob, for the questions. In addition to what Melissa and Catherine has mentioned, I just wanted to give a quick shout out to HRSA's current effort. Maybe Jeff can detail that a little bit. The ongoing work to systemically improve how we do lived experiences research and at the research networks that HRSA is funding. I think those are ways to address, hopefully, part of the potential bias questions and make our lived experiences research more complete in the future.
Thanks. Michelle?
Hi, it's Michelle Kajana, committee member. I agree with Bob and Melissa. I was thinking about that as Bob was talking about sort of the ascertainment bias, and that's something I always worry about in these kinds of studies. And along those lines, I think it's really important, as Melissa said, to be sure that the research is actually truly patient-driven and not, hey, let's get some patients together and come up with a project and then use the patients to prove our point. The other thing I was wondering, with some of these other patient-driven research sort of organizations out there that sponsor that we heard about today, is there any way that some of these opportunities could be sort of placed in one area? Because someone has to really know to go look at this organization and that organization in order to find these opportunities. And I was wondering if there's a home where they could live sort of together. I guess not.
I think, Michelle, you might be providing food for thought that our speakers in the different organizations might be prompted to think about how these efforts could go together. Hey, Jeff?
Actually, I was going to respond to something that Mike raised before, so I'll let maybe Nora has a specific answer to her question.
Nora?
Oh, I was just going to say briefly that we could certainly talk to our communications folks at PCORI about publicizing this, ways that publicizing PCORI's research opportunities and engagement award opportunities in ways that might be more accessible and a better place for folks to find them. We always are open to that.
And this is Jeff, and I think I want to really make a clear distinction between a couple of things that have come up that I think both Michelle and Bob brought up. And that is that what we're talking about is including patients and families and people with lived experience throughout all aspects of all research, right? So not just research that's about patient outcomes. So for example, in the CRAB-A research that we looked at, remember that we heard from families. Irritability is one of the most important things for how we experience our child, and it's really awful. And we really need to address this. We heard that from a number of folks, including clinicians as well. And if you looked at the research, though, there wasn't, say, an irritability scale asking parents, did things get better once you had a bone marrow transplant? So something that was really important to families was not included in the outcomes of the research. And so this is, the ascertainment bias is true of all research we do all the time. And the idea of making sure that families and patients' lived experience is included from the beginning means that the outcomes that you look at, right, PCORI, patient-centered outcomes, the outcomes that you look at are the ones really relevant to families and patients. So the ascertainment questions are for sure there, especially if you have a patient, involved in trying to help you figure stuff out. But the idea is that all of our research should be focused on these kinds of things. And if you think about what we've done as a committee over the last year and a half, we've said, well, how do we make sure that the public comments, the voices of families and people with lived experience gets included in the evidence base? And we had a series of speakers that talked about the ways you did it. And today it was great to have you, Mike, and our federal partners talk about all the different ways that this is already being done and some of the funding mechanisms available. And the last thing I want to add is that this is, and Mike, you brought this up and we talked about this before, this is absolutely not trying to add yet another hurdle, another thing for nominators to have to do. This is to make sure that the research we're already doing includes a way of making sure that the outcomes include what matters to families. And at HRSA, we fund relatively small amounts of research. And what we're really focused on in our research network that you brought up a couple of times is making sure we have good measures of family outcomes. And I think we're planning a presentation a little bit later to talk about how we're just doing this in newborn screening. Thanks.
Thanks, Jeff. Natasha, last question before lunch. Not to put on pressure.
No pressure, it's okay. Natasha Bonham, Genetic Alliance. Thank you for the presentations. I have a comment and then a question. I think this discussion around ascertainment bias is a really important one, but I do notice that it tends to come up quite frequently when we're talking about patients and patient perspectives and lived experience, and doesn't necessarily always come up in other parts of research where we know that can also be the case, right? Depending on which clinicians you may be speaking to around a certain topic, there may be some bias there. So just trying to think of, this important topic and putting it in a broader context of, people have biases in different ways because of different reasons, and just thinking about that. And it was noted, thinking about, there's some advocacy groups that are really strong leaders and have a very strong voice and have a range of different mechanisms to engage their memberships. And I think that's similar to professional societies. There are some professional societies that are super tapped in with their membership and all their members seem to be really excited, and others not quite the same. So just putting it within that context. My question to all of the panelists is really about compensation and broader support for families to be able to participate. We still see at Expecting Health, families being invited to advisory committees, being asked a lot of questions, and not being necessarily provided any compensation or very minuscule compensation, like a gift certificate. Whereas we would never ask a PhD, a PI or co-PI to do that work based off of, gift certificates or smaller stipends. We know that this is their living. So just wanted to see from your perspectives, how your agencies or organizations have dealt with that or are thinking about that type of compensation so that you can get families who have a range of experience involved in many different ways. Thank you.
Nora.
Yeah, so PCORI has a compensation framework for stakeholder partners, including patients and caregivers, as well as our foundational expectations that guide how how they should be involved throughout the process and properly compensated. So I really encourage you to check out all our resources, because we really think this is a really important topic, and agree with the points you're making wholeheartedly.
Mike?
That's a great question. I just want to share a little bit of our own experience. We do provide a small token of appreciation to the families who enroll in the Guardian study, as we do a lot of surveys, the exit survey, the non-participant survey, and the follow-up survey. So we do show that. I think it is, in general, appreciated by the participating families. In particular, I think for the families who are affected, and as most of the advocates in the areas will be, families are certainly very motivated to share. So it's not so much of a question that we necessarily need to compensate them, but I think it is recognizing that this will help more families participate in the research, because some of them are probably not in best positions to take up an hour or two out of work to participate. And so I think this is more of a way to enable those advocates who might not otherwise have the opportunity to participate, and it helps to address the ascertainment bias that was mentioned earlier as well.
Thanks, Mike. Melissa?
We encourage our investigators to compensate families whenever it's feasible. And in fact, for some of our Down syndrome related activities, we actually use a gift fund to compensate self-advocates and advocates who participate in any of our webinars. They receive an honorarium that is not a trivial sum of money. And we also host workshops. And when we invite self-advocates with Down syndrome to speak or help out as greeters or whatever they're doing, we also provide compensation to them. And I think what it really shows is that you respect their presence, you welcome their commitment and their input, and you really want to make sure that they are being appropriately rewarded for their participation. Thank you.
Well, this has been a great panel. I really appreciate everyone's input. Presentations were thoughtful, full of information. I think what we were really after was what you presented, how we can do things, how we can start to think about opportunities to fund and conduct research that includes the very important outcomes of impacts on families and patients outside of what we often numerically count. So the lived experience of both is just so important. So I really appreciate your time today, the information you shared, and I hope that our community looks at the rich opportunities available to us in designing research that can inform our evidence review group and our decision-making going forward. We're going to move into lunch, and we're running a little late. So, boy, in a show of generosity, I'm going to extend lunch until 12:35 Eastern time, so 5 minutes. Let's try to restart at about 12:35 Eastern, and we'll see you all then. Thanks. I think we're just missing one person, so I'm going to go ahead and respect the time and the resource that we have in our folks presenting public comments, and I have an order, and I'm going to follow that. And W.G. Stewart McKenzie, you are first. I see you.
Hello, good afternoon. Thank you very much for this opportunity to speak before the Advisory Council today. My name is Stewart McKenzie, and I'm a pediatric orthopedic surgeon here at Nemours Children's Hospital in Wilmington, Delaware. It's my great pleasure to speak to you in advocacy for patients and families with mucopolysaccharidosis type 4A, otherwise known as Morquio syndrome. I serve as a surgical director of our multidisciplinary dysplasia program here, and I'm proud to say that we are the country's foremost program for patients with rare skeletal dysplasias. I'm very involved in research and treatment of children and young adults with Morquio syndrome, including an NIH funded study under which I see nearly 100 patients per year. To date, I would describe our treatment of patients with Morquio syndrome as entirely reactionary. Classically, these patients are diagnosed after the age of 3 years old, as they are born appearing typically developed with physical manifestations of their lysosomal storage disorder, which begin at birth, yet take years to become apparent. This diagnosis can be delayed even further in many cases, and multiple times I've met families and had to discuss the need for urgent surgical decompression and spine fusion at that first visit. The surgical burden on these Morquio patients is incredibly high, and I'm very proud to provide improvement in quality of life for my patients, but I'd be much happier keeping these patients healthier and more active with less surgery. I look forward to a time when we can be more proactive in the care of these children. Currently, our medical community has an excellent treatment option for Morquio syndrome in the form of enzyme replacement therapy. Weekly infusions provide the deficient enzyme to our patients and results in benefits of muscular endurance, decreased fatigue, and improved pulmonary function. We know that early initiation improves function. With our current dysfunctional diagnosis pathway, many patients are receiving the enzyme at an advanced age. This treatment has been proven to be safe and effective, is approved and in use around the world, but our patients deserve access sooner. My partners and I here at Nemours are currently involved in researching a gene therapy option for these patients, and I look forward to the day when our patients can have both early diagnosis and early access to care. And so for this reason, today, I'd like to strongly support the need for newborn testing for Morquio syndrome to give these bright and capable children every opportunity available to them.
Thanks so much, Stuart.
Thank you.
Comments? I'd like to now turn to Christine Tippett. I don't know that I see Christine on the screen.
She hasn't joined yet.
Okay, we will return and see if she does join us coming up. And so I'd like to turn to Abby Cook. I think you need to turn on your microphone.
Good afternoon, and thank you for this opportunity. Are you hearing me now?
Yes.
Okay. Good afternoon, and thank you for the opportunity to share our story. My name is Abby Cook, and I'm here on behalf of my sons and the CTX Alliance, the sole patient advocacy group dedicated to cerebrotendinous xanthomatosis, or CTX. We look forward to submitting a preliminary nomination early next year for your consideration to add CTX to the recommended uniform screening panel. Today, I wanted to share with you the Cook family's experience with CTX so that your committee and others understand why newborn screening would be life-changing for families like ours. In their first 10 years, our beautiful and clever sons, Ben and Zach, were diagnosed with a series of cognitive and physical issues, learning disabilities, central auditory processing, speech and executive function disorders, hand tremors, nystagmus, GI problems, and for Zach, behavioral issues. We sought out the best therapists and doctors, arranged school accommodations, and supported their needs as best we could. The next decade brought even more diagnoses: ADHD, nonverbal learning disorder, and for Zach, autism spectrum disorder. Meanwhile, our daughter Becky, untouched by these issues, helped her younger brothers, but she was profoundly affected by their struggles and our growing distress. In his 20s, Zach's health took a steep decline. He became troubled, withdrawn, and sometimes talked about ending his life. He slept excessively, had psychotic episodes, and no doctor, not even a leading neuropsychiatrist at an elite medical school here in Boston, could diagnose or slow Zach's deterioration. Ben, his older brother and best friend, felt he could no longer recognize Zach All of us grieved as a feeling of helplessness took hold. Then, at age 26, Zach's Achilles tendons began to swell. An MRI revealed xanthomas, but it took 4 more years for us to learn of this finding and to discover that these swellings and Zach's other symptoms pointed to CTX. When I searched for images in medical journals of Achilles tendon xanthomas, they looked just like Zach's. The xanthomas were caused by a rare disease called cerebrotendinous xanthomatosis, a disease also causing devastation in the brains of these patients. My husband and I immediately requested confirmatory diagnostic testing. Zach was finally diagnosed 2 years ago, which led to Ben's diagnosis as well. Zach's 30-year ordeal has saved his brother's life. Today, our sons are fortunate to receive specialized care from a team at Mass General and from laboratory researchers like Dr. DeBarber. The disease has left an indelible imprint on us and continues to injure our sons' bodies and minds. Treatment at this stage of life, after the disease has been untreated for more than 30 years, can only do so much. We, especially Zach and Ben, face the consequences of a late discovery of this progressive but highly treatable condition. Newborn screening for CTX would allow families like ours to intervene early when treatment could prevent or halt the progression of symptoms and to avoid a diagnostic odyssey like ours. Thank you for considering the impact newborn screening would have on CTX families and for listening to our experience with this disease.
Abby, thanks so much for sharing your story. We appreciate it. I'd like to now turn to Robert Steiner.
Hello. I'd like to thank the committee for the opportunity to share some thoughts about newborn screening for cerebrotendinous xanthomatosis. You heard Abby Cook's eloquent presentation, and unfortunately, the story of the delayed diagnosis is all too typical in CTX. My name is Robert Steiner, and I'm a physician scientist and newborn screening professional at the University of Wisconsin School of Medicine and Public Health. I do not represent the university or the state today, but rather I'm speaking on behalf of the CTX Alliance, a patient advocacy organization that intends to submit a preliminary nomination for consideration of CTX for addition to the RUSP. I'm an officer of the CTX-A and also disclose that I've served as a consultant for companies that market treatment for CTX. I've diagnosed and cared for patients with CTX for more than 2 decades and am supporting efforts to implement newborn screening for CTX because I've witnessed firsthand the benefits of early diagnosis and treatment of the condition. CTX is a genetic metabolic disorder caused by mutation of the CYP27A1 gene, which encodes an important enzyme in bile acid synthesis. Deficiency leads to impaired production of bile acids, in particular chenodeoxycholic acid, or CDCA, and accumulation of cholestanol and bile alcohols, which leads to the diverse clinical signs and symptoms of CTX. CTX presents with a wide spectrum of life-altering clinical manifestations that can vary significantly in onset and severity. In infancy, affected individuals may experience liver disease that can resolve, but also can be fatal. Chronic diarrhea is usually present in infancy and can significantly impact growth. Additional childhood symptoms may include bilateral juvenile cataracts, seizures, and intellectual disability. As the disease progresses, spastic paraparesis, cognitive decline, and dementia ensue. Psychiatric symptoms are also common from childhood onward and may be completely debilitating. Additional features, as you heard, include tendon xanthomas, heart disease, and osteoporosis. Now, CTX is an infancy and childhood onset relentlessly progressive disorder. The condition is not divided into mild versus severe or early versus late subtypes. The range of birth prevalence for CTX is estimated at about 1 in 70,000 to 1 in 234,000, depending on the population studied, and that represents the most recent estimate. CDCA, in the form of a simple tablet taken 3 times a day, has been used for 40 plus years as the standard of care for treatment of CTX, since initial trials showed it was safe and effective to stabilize or improve symptoms and prevent disease progression. Additional clinical evidence includes data from long-term treatment studies that have further shown that initiating CDCA therapy at an early age correlates with better outcomes. In some of these studies, younger siblings benefited from their older siblings' diagnosis and showed that treatment in childhood can prevent disease symptoms. A recently published consensus clinical guideline suggested treatment start at diagnosis, even in infancy. CDCA is currently FDA approved for treatment of gallstones and is prescribed off-label in CTX, although it is considered a medical necessity for patients with CTX by both the FDA and the NIH. A study to demonstrate CDCA's safety and efficacy has recently been completed with a resultant new drug application for CDCA and CTX that is currently under consideration by FDA. Cholic acid, an alternative therapy, is already marketed for bile acid synthesis disorders. An average 2-decade-long diagnostic delay still persists due to the rarity as well as variability in presentation of CTX, with symptoms overlapping with more common conditions. Based on prevalence estimates, CTX is significantly underdiagnosed, and yet confirmatory diagnostic testing is widely available. Universal newborn screening is the best approach to mitigate late and underdiagnosis. Early identification, diagnosis, and treatment are critical to arrest disease progression and prevent often irreversible intellectual and physical disability. Newborn screening would also spare families the burden, both financially and emotionally, of the average 2-decade-long diagnostic odyssey that you heard a bit about so eloquently from Abby. Tandem mass spectrometry methods to screen newborn dried blood spots for CTX have been described and successfully further tested using instrumentation and general procedures already in use in newborn screening labs. We greatly appreciate the opportunity for efforts toward newborn screening for CTX to be discussed today. It's a devastating disease that is typically diagnosed too late to prevent severe complications. Newborn screening can change that. We thank you for the continued hard work of the committee on behalf of children affected by rare diseases, for whom newborn screening will provide tremendous benefit. Thank you.
Thank you, Robert. Next, we have Brandy Yoko.
Hi. Let me make sure I have my stuff working. Okay. I wanted to thank Dr. Kalanj and the committee for allowing me to speak today. My name is Brandy Yoko, and I'm here on behalf of BEAR, biliary atresia research and education in support of adding biliary atresia to the RESP. I'm eager to see their application move successfully through this process, as early diagnosis is imperative to possibly avoid transplant or death associated with this disease. My son was born in February 2022, when the common understanding was that the surgery needed to diagnose and treat this disease, known as the Kasai, was most effective if done within the first 6 to 8 weeks. We now know, based on several reviews of studies worldwide, that it actually has the best chance of working within the first 30 days of life. Currently, the majority of BA babies are diagnosed on average around 3 months old. My son got his Kasai at 6 weeks exactly, and it pretty much failed immediately. He was evaluated for liver transplant less than a month later and was listed in August. His paternal aunt was thankfully deemed a near perfect live donor match, and he had his transplant in November 2022. Many people seem to think transplant is kind of plug and play, but it's far from, due to the side effects, the biggest being from Tacro, which most transplant patients will require for life. A month post-transplant, my son got EBV. A month after that, an ulcer found in his duodenum resulted in a diagnosis of EBV-positive monomorphic PTLD consistent with diffuse large B-cell lymphoma due to the immunosuppression allowing the EBV to grow. A severe case of norovirus 2 days later resulted in needing rituximab infusions for the PTLD. He was taken off Tacro during that time to let his immune system kick in against the EBV, and has since had 2 episodes of mild rejection over a year apart, the most recent being this past June with his liver enzymes still being unstable. Along with PTLD, he's been diagnosed with FPIES after ruling out EOE and has a brain MRI scheduled next week for central sleep apnea found this past April during a sleep study ordered due to breathing issues from adenoid hypertrophy before starting on Flonase. Unfortunately, none of these are uncommon post-transplant complications. Throughout all of this, I still have to work. I take Teddy to his appointments and any emergency trips or hospital admissions, but I have to ration my PTO, so I work extra around these events as having a medically complex child isn't cheap in this country. We still mask. Neither of my children have gone to daycare or preschool yet until Teddy's liver is stable, and most family events take place outdoors if we even join at all. My son's transplant hospital isn't one that gives the MMR or varicella vaccines to transplant patients, so in today's ever-growing anti-vax climate, sending him to school is a terrifying thought. Transplant is a marvel, absolutely, and my son would not be here without it. But I know far too many babies who didn't make it because of a late diagnosis or complications from transplant. Avoiding transplant is the most desirable outcome that every BA baby and their family deserves. And the change of one simple test from a total to a split bilirubin test directly after birth or by the first 2 weeks of birth can diagnose this disease in time to have an effective Kasai performed. Unfortunately, most of the physical symptoms can be excused away until it's too late, so this is the best way to help avoid a late diagnosis. About 50% of the pediatric patients currently on the transplant list are for livers, and biliary atresia is currently the #1 cause for pediatric liver transplant. This one simple test change from a total bilirubin to a split bilirubin could keep other babies from experiencing everything that my son and others have had to endure. Thank you for letting me speak today.
Thanks so much, Brandy, and thanks for sharing your story. And I know your schedule's busy. I'm glad you had time to present today. Appreciate your presence and your comments. Thanks so much. Next, I have Tabayan Rabani.
Good afternoon. Thank you for this opportunity. I'm Dr. Tabian Rabani from Stanford University's Pediatric GI Department. Today, I want to share a story about the profound need for newborn screening for biliary atresia, the #1 cause of solid organ transplants in pediatrics. Early in my training, I encountered a mother concerned about her baby's yellow eyes and skin. She told her pediatrician, "My baby's eyes are yellow." Her concerns were dismissed with explanations like, "Sometimes Black babies have yellow eyes." I still have no idea what that comment even means. Jaundice lasting longer than 2 weeks of life is not something that to be dismissed lightly. Her child had biliary atresia, and by the time she reached us, her opportunity for intervention had slipped away. Now, this story is not unique. Children of color are disproportionately impacted by delayed diagnosis, often referred to specialists after the critical window for intervention has closed. They then face a future that includes either late-stage intervention or liver transplants. But transplantation isn't a cure for biliary atresia. It's a complex, lifelong management plan that introduces new risks and challenges such as immunosuppression, infections, possible retransplantation, and elevated risks of certain cancers. The only effective treatment for biliary atresia is a surgery called the Kasai procedure. But to have the best chance of working, it needs to be done within the first 4 weeks of life. After this window, the effectiveness drops, leading many children down toward the liver transplantation. The only signs in this critical period are jaundice and pale stools, and they are often missed or even dismissed. There is a solution that can prevent these delays. A simple direct bilirubin test added to the total bilirubin that most newborn nurseries already perform could be the answer. This isn't a burdensome addition and doesn't require any extra blood or a complex new procedure. It's what we call the point of care screening, a method that already established for conditions like congenital heart defects and hearing tests. Newborns across the nation already undergo total bilirubin testing, either via serum or transcutaneous methods to assess for hyperbilirubinemia. By fractionating or splitting it, that existing test to include direct bilirubin, we can screen for biliary atresia with minimal disruption to the current practices. Direct bilirubin screening is not only simple and accessible, it's effective. It has a high sensitivity and specificity with a low rate of false positives. My experience with Miss BA patients have led me to implement screening for this disease in the third largest hospital in Texas and in the largest birthing hospitals in the Bay Area, where I'm currently based, with plans to expand to 3 more institutions across the US. Our protocol is straightforward. We test at 24 or 48 hours of life when they're already getting the newborn screen and possibly their total bilirubin check with no extra blood. And if the direct bilirubin is elevated, we retest at 2 weeks of life. And if it's still elevated, we refer to GI, giving these children a chance to undergo the Kasai procedure early and avoid the burdens of liver transplant. I'm here before you today, not only as a physician, but as someone who has seen these families and families who love their children deeply and trust the healthcare system to guide them. Biliary atresia screening is safe and proven and a feasible addition to the newborn panel. It could prevent many families from needing to navigate the challenges of late-stage diagnosis or lifelong management of transplant complications. The need is clear. With a simple change, we can save lives, improve outcomes, and give children a healthier future. I urge the committee to consider the profound impact of adding biliary atresia to the newborn screening panel. Chairman Kalanj, Bayer is thankful for you and the committee's review of their nomination package this year. We look forward to the continued work with you so that biliary atresia can be added to the RUSP in a way that is sensible for hospitals and hopeful for babies. Thank you very much.
Thanks, Tamayan. Appreciate it. Next, we have Bo Hoon Lee.
Hi, and thank you for the opportunity to speak today in support of Duchenne muscular dystrophy, currently under consideration by the committee. My name is Dr. Bo Lee. I'm a child neurologist at the University of Rochester, where I currently direct the Pompe and spinal muscular atrophy newborn screen follow-up clinics and co-direct the pediatric neuromuscular program. As such, I have experienced how transformative newborn screening can be for patients that I care for. We are a certified Duchenne Care Center and follow approximately 140 patients with Duchenne and Becker muscular dystrophy. I'm lucky enough to live in New York State, where there's already legislation for DMD newborn screening to start. And once it does, I'll direct our New York State designated neuromuscular specialty care center that will receive referrals for DMD at my institution. Additionally, I'm interested in leading a clinical and research consortium in New York that will work towards characterizing the early natural history and standardizing the clinical care in babies with Duchenne muscular dystrophy. As you've heard before, data from MD StarNet and others have shown that despite over 3 decades of broad efforts to improve clinical identification with CK-based screening in infants and toddlers, the delay to diagnosis persists with an average age of diagnosis at nearly 5 years. You keep hearing about the diagnostic delay as it's a frustrating and all too common situation that those of us who see and treat Duchenne encounter. However, in the most recent past, that frustration is further compounded by the fact that we have a growing number of treatments that would have benefited the boys. In the past year alone, I've met and diagnosed multiple children with DMD several years after clear clinical symptom onset, including a boy who had already entered the late ambulatory phase of the disorder and came to me never having had a CK checked. This is unacceptable. The equity and justice impact alone of DMD screening will be significant, as multiple studies have already demonstrated that children of underserved minority groups are disproportionately affected by the diagnostic delay. In a study out of UVM, the delay was also more pronounced in boys with co-occurring neurocognitive diagnoses like autism. I strongly believe that newborn screening will relieve the differences in time to diagnosis against these disadvantaged groups. Importantly, in 2024, DMD is a treatable disease and earlier treatment is better. The number of therapeutic interventions available to our patients has grown significantly and continues to expand. We have multiple gene-based drugs and multiple drugs with downstream mechanisms of action that have been FDA approved for Duchenne. This includes Elevidys gene therapy, which is currently approved for boys older than 4 years of age. And even with the expanded approval allowing treatment in boys past their 6th birthday, by the current average age of diagnosis, many are still being rushed through the complicated and stressful decision-making process of obtaining approval and access to therapies like ELEVIDYS. When the diagnosis is delayed, there's irreversible muscle damage that has already occurred. And the opportunity to stabilize the progressive muscle fiber loss with corticosteroids and other disease-modifying drugs are as early as possible is already narrowed. Furthermore, an early diagnosis provides actual knowledge beyond pharmacologic intervention. We should be careful not to undervalue the benefit of earlier access to support services, early implementation of appropriate diagnosis-guided ancillary therapies, and school preparedness in these young children. This benefit extends not just for the early differences in motor performance, but also in screening for and intervening on the highly coincident language and speech delays and spectrum of neurobehavioral diagnoses that we see in DMD, like autism. For these reasons and many others, I believe that it's time for DMD newborn screening, and I'd like to thank the committee for the time to speak and for your continued consideration in moving newborn screening forward for Duchenne.
Thank you for your comments. I appreciate it. I'd like to ask Ashley Stimac to present next.
Hi there. My name is, good afternoon. I'm Ashley Stimac. This is my husband, Tyler. He's joining us as well. And I'm here as an advocate, a labor and delivery and NICU nurse, and a parent to urge the addition to Duchenne to the recommended uniform screening panel, or RUSP. Let me introduce you to my son, Connor. Connor's journey, like so many with Duchenne, highlights the serious consequences of delayed diagnosis. As parents, we noticed Connor was missing key milestones. Despite being taken to multiple pediatricians and neurologists, we were told repeatedly that since he was cognitively fine, there was no need for further testing. His gross motor delays were downplayed, and valuable time was slipping away. It took our insistence as parents and me as a nurse to demand these labs. I actually had to order the labs myself and request them from the pediatrician. The results came back and they showed elevated liver enzymes, an indication that expedited our access to genetics department. Prior to that, our genetics department was making us have a 1-year wait list to get in to see them. We feel so fortunate that Connor was diagnosed when he was. One especially close call involved surgery Connor had scheduled. Had we not discovered his condition just a week earlier, the use of general anesthesia could have had a devastating outcome, given Duchenne's unique risks. Early knowledge of Duchenne can mean the difference between safe medical care and preventable tragedy. Thanks to his diagnosis, Connor now receives early intervention. He is in aquatic therapy, physical therapy, OT, and physical therapy. He's also able to start steroids, a treatment that helps preserve his muscle function. And with advancements in medicine, we're hopeful that he may soon benefit from other therapies currently in clinical trial. But early detection offers more benefits. For families, it provides precious time to process a life-changing diagnosis, allowing thoughtful decisions rather than rushed choices. It means the opportunity to adjust insurance plans to cover specific needs in advance rather than reacting mid-year, which often adds unexpected stress and expense. Early diagnosis also prevents the years of misdiagnosis that many families face, sparing them unnecessary medical costs, endless appointments, and the frustration that ripples through every aspect of the family life. It allows for financial assistance that can be a lengthy process and often results in reduced medical costs overall. With early awareness, families can make important life decisions like purchasing single-story homes that's accessible for wheelchairs, in accessible schools, or planning for vehicles that can accommodate a wheelchair. Decisions that become much more costly if made reactively down the road. Adding Duchenne to the RUSP would empower families to make informed decisions early on, giving children like Connor the best possible chance at a higher quality of life. Please make sure that no other families endure the endless delays and hardships we face. We have the power to change the course for thousands of children. Thank you.
Thank you, Ashley. Now, Catherine Anderson.
Hi, good afternoon. Thank you to Chairman Kalanj and the members of the ACHDNC for the opportunity to speak today. My name is Catherine Anderson, and I'm the Community Research Manager at Parent Project Muscular Dystrophy. I'll be sharing an update to PPMD's work to quantify the benefit of early treatment in Duchenne. Duchenne is progressive and systemic, gradually robbing children of the mobility to play tag, the arm strength to hug their families, and the pulmonary strength to sing their favorite songs. There's no cure yet, but Duchenne is treatable. Boys often first present with speech and developmental delays, for which early interventions ensure the best possible outcomes. And we now have 8 FDA-approved medications that are specific to Duchenne, giving patients more quality years of walking with healthy hearts and lungs. Duchenne is genetic, but in about a third of cases, it arises from a random genetic variant. This means that every American expecting a child could face this journey and the risk of a long, agonizing path of uncertainty before a diagnosis is even confirmed. Families often notice delays by age 2, but the average age of diagnosis is still around age 5, and many are diagnosed even later when their muscles are already in severe decline. At PPMD, I meet many families with newly diagnosed children, and the story that I repeatedly hear from families of children nearing age 10 is that I knew something was wrong and I pushed for answers in every way I could, and now I've lost so much time. These families do everything right and still spend years fighting through unnecessary tests, costly specialist visits, or even damaging therapies, all while watching their children stagnate and regress without appropriate treatment. This is particularly pronounced for families of color who face more disparities with longer paths to diagnosis. All families deserve the opportunity that newborn screening provides to get the right therapies at the right time for them, including securing care for developmental delays and taking advantage of the 7 life-changing FDA-approved treatments for babies 2 or younger. There's tremendous power in your hands to change this story. Newborn screening is the only tool that will empower all families to make fully informed treatment decisions while their children still have muscle to preserve. PPMD is leading an initiative to promote research on the impact of early care. 4 of our certified Duchenne care centers are submitting data for a pooled cohort of boys treated with steroids. The study will assess whether treatment before age 4 yields better outcomes compared to later treatment. The analysis will include variables such as the participant's variant, steroid schedule, and other Duchenne treatments. On March 5th, 2025, PPMD will host a virtual symposium focused on the early treatment in Duchenne. The results from the collaborative study will be presented alongside insights from other experts in DMD care. Let's bridge our decades-long work improving care with the advancements we have in diagnostics, treatment, and long-term follow-up. Together, we can change the narrative of Duchenne to one of hope, in which parents have the clarity and assurance of early diagnosis to make timely decisions for their children's treatment. Thank you to the committee for your continued consideration of Duchenne to the RESP.
Thank you, Catherine. Now I'd like to turn to Christine Tippett.
Hi, thank you so much for finding me. My name is Christine Tippett. I'm here to advocate on behalf of adding Morchio to the RESP. My family and I live in Littleton, Colorado. Our 12-year-old son, Cooper, was born September 12, 2012, a healthy baby boy. Our world crumbled 17 months later when we received Cooper's diagnosis of Morchio syndrome. Our diagnostic journey was relatively short at 7 months, but a diagnosis at birth would have made a world of difference. The thing I remember about diagnosis was the 8 days when we didn't know it was happening, when we were told, we think it's an MPS, but don't Google it. We were confused and scared. The pediatrician made calls to get us into the metabolic clinic ASAP. I sensed an urgency that scared me. The emotional and physical effects of the stress this puts on a family is indescribable. It's a terribly dark time. A diagnosis at birth would have come as a surprise, but I'd prefer it over a journey which felt like watching a train approach as we were tied to the tracks. If at Cooper's birth we were given a diagnosis, we would have been 17 months faster to not only life-altering ERT, but the equally important Morchio community. I can tell you from experience, you can't find anyone who remotely understands what you're going through while sobbing in the women's room at Children's Hospital. Cooper himself will tell you how important infusion day is, how he feels tired if he misses infusion for more than a week. Cooper's first grade teacher shared with me that she could tell which day Cooper had infusion because the following day, he was super fast on the playground, a big difference from the other school days. A month after diagnosis, we found our community 1,500 miles away. A listening ear on a confident, compassionate, knowledgeable mom of a Morchio daughter. My aunt found Stephanie sharing her daughter's journey on the internet. Families dealing with a rare disease desperately need community. They need someone who truly hears and sees them. They need a seasoned parent who can tell you who to call at which doctor to get answers. A comrade at arms to send you to the National MPS Society to make more connections and find resources. Parents need a community who can share their experiences, listen to their fears, and hold their hand during life-changing moments. I know that an earlier diagnosis wouldn't have given my 38-inch tall, sports-crazed boy the chance he wants to play in the National Hockey League. But an earlier diagnosis would have given his family a better, more educated start for his and our future. For all our kids, all we want is the chance to do the very best. A diagnosis at birth gives kids with Morquio a chance for the very best. Here is Cooper meeting his hero, Colorado Avalanche's Cale Makar, this week. Where's Cooper? Oh, he's the short one. You'll find him. He's there. The photo certainly is one for the highlight reel. I'm hoping the next part of the highlight reel is seeing kids with Morquio like Cooper diagnosed at birth. Lastly, here's Cooper when he did find his community. 2 boys sharing his same journey with the same diagnosis. So thank you very much for your time today.
Thank you, Christine. Thanks to all, especially parents and advocates for presenting today and sharing your stories. These are very important for the committee to participate in, to hear, to help understand the importance of the work that we do here on the advisory committee. I also want to appreciate the work from the clinicians who dedicate their lives to taking care of these children with rare diseases and trying to alter their health and life trajectories. With that, I will close the public comment period and we'll move on in the agenda. Next up, we're going to hear from Drs. Don Bailey and Elizabeth Reynolds from RTI International. Going to provide an update on their work on assessing domains of family outcomes in considering what should be measured for quality of life for both individuals and families identified with genetic conditions through newborn screening. HRSA provided funding to support RTI's project. This work is a direct response to the things the committee has heard from various stakeholders and, again, today, during public comments. It also aligns with HRSA's Blueprint for Change, a national framework for a system of services for children and youth with special healthcare needs. One of the 4 critical areas of the framework is quality of life and well-being. To introduce our speakers, Dr. Don Bailey is a distinguished fellow at RTI International, where he is a member of RTI's Genomic and Translational Research Center. He has an extensive record of publications on a variety of topics related to disability, early identification, early intervention, newborn screening, and family support. He is a senior science advisor for Early Check, a statewide research project to help prepare newborn screening for new conditions and new technologies, with a current focus on whole genome sequencing. He also leads this project funded by HRSA to identify and develop ways to assess family outcomes of newborn screenings. From 2011 through 2017, he served as a voting member on the U.S. Department of Health and Human Services Advisory Committee on Heritable Disorders in Newborns and Children. I will go ahead and introduce Dr. Elizabeth Reynolds, who is Manager and Research Public Health Analyst in the Genomic Ethics and Translational Research, or GET, or GIT program at RTI International, where her interests include rare and genetic diseases, patient registries, and early developmental outcomes. She is leading a project examining links between newborn screening and early intervention, developing an assessment to evaluate family outcomes after genetic diagnoses, and creating a tool to integrate electronic health records into patient registries. She is also the founder and executive director of the CHAMP Foundation, a patient advocacy group with the mission to support research to find treatment and a cure for single large-scale mitochondrial DNA deletions like Pearson syndrome. Welcome to both Drs. Bailey and Reynolds, and I'll turn things over to you, Don.
Can you hear me okay?
Yes.
Great. Yeah, thanks for that. Thanks for that introduction. And thanks for the opportunity to provide an update today for the committee. I just want to start by saying how inspiring it is to hear the stories that families shared with the committee. We hear these stories every meeting, and they really help shape our perspectives and ground us on what's really important and why we do newborn screening. As all of you know, newborn screening focuses primarily on child outcomes, but many of us believe that family outcomes are also important. And so this is the focus of the work that we're doing. We're very appreciative of HRSA for supporting this work. Next slide, please. So, we gave quite a bit of background to this work in a previous committee meeting, so I won't go through all of that again. I'll just say that this is grounded in some early work we did many years ago in early intervention, where we were looking at how families benefit from and what are their outcomes from early intervention programs for children with developmental disabilities. And so this extends and expands that work to a new context, newborn screening. So obviously, we all know that families can benefit from newborn screening. But what are those benefits? We don't know a lot about them. We can speculate on them. We can describe them. We can hear stories about them. But we don't have a good way to measure them. And so we did develop a measurement tool, the Family Outcome Survey, a Family Outcome Scale, as a part of early intervention. And we're now going to be doing the same thing with in the context of newborn screening. So this project is the first step in developing such a tool. So as you can see from this graph, we've been spending, or this figure, we've been spending quite a bit of time getting input from a variety of different groups. And if we could go to the next slide, I'm going to give you a high-level view of what we've done so far, and then Dr. Reynolds will give you more detail on each one of these steps. So the first thing we did was establish a fantastic expert advisory committee. We've engaged the regional genetic networks to get input. We conducted a major literature review. We've held focus groups. And all of this was designed to help us develop an initial set of what we call outcome domains. Ultimately, we'll have a tool with a number of different items on it, but those items need to link back to particular domains. And that's where we want to start, is understanding what are the chunks? What are the chunks of outcomes that would be important to examine as a part of newborn screening. So out of all of this work, and based on it and our previous work, we've now drafted an initial set of outcome domains. We've shared those with a number of groups already, and we are in the process now of getting ready to revise those outcome domains, after which we will distribute them widely for another round of input. And this will be a very large-scale effort that Elizabeth will describe. We're also preparing and will publish eventually a manuscript describing how we got to these outcomes. These will be important grounding for our work. And then we'll be moving from that into developing a scale. So I'm going to turn it over now to Dr. Reynolds, who will share more details about each of these activities. We know you have a very busy schedule, so we'll go through these pretty quickly and look forward to a more detailed presentation in a subsequent meeting.
Okay, thank you very much, Don. You can please go to the next slide. Okay, great. So now, as Don mentioned, I'm going to be providing some specific details about the methods that we use to get to this point. And so here you can see this is our team of expert advisors that we set out with the intention to include participants with a diverse background and experience to inform our overall project objectives. And ultimately, this was our 13-member advisory committee. I think there are some people here on this call today from the committee, and it included patient advocacy groups, parents of children who were identified through newborn screening laboratory and follow-up directors, clinicians, genetic counselors, APHL representatives, and family researchers. Our advisory committee met 3 times over the last 7 months. The first meeting was in March, and we focused on our project overview and goals. The second meeting was in May, and this was where we had our presentations from the regional genetic networks that I will discuss a little bit more about in a minute. And we had our final meeting in September, and this was the first round of feedback and reviewing that we had on our set of drafted outcomes. Next slide, please. The regional genetic networks were originally funded by HRSA to develop and support an infrastructure system relating to genetic services. And there are 7 RGNs, and each receives supplemental funding from HRSA to identify family outcomes after newborn screening. And to fulfill this requirement, the RGNs collected feedback from families using a variety of different methods, including listening sessions, focus groups, and surveys. And given their unique access to these families, and our aligned priorities, we invited each of the directors of the RGNs to share their findings at our second advisory committee. And we asked them to present using a standardized template and share about the specific activities they used to solicit feedback, describe the high-level characteristics of the participants, and identify the 5 most important outcomes that families brought up following a newborn screening diagnosis. We have 4 RGNs accept this invitation, including NIMAC, New England Regional Genetic Network, the Mountain States Network, and the Heartlands, and they shared their results with our advisory committee. Go to the next slide, please. And as Don mentioned, also, we conducted a systematic literature review of articles related to family outcomes and newborn screening. And specifically, we used these search terms and we identified 149 articles to review. For each, we conducted a thematic analysis using some of our pre-identified themes. And these pre-identified themes included access to information, access and use of high-quality services, families' ability and skills to meet the needs of their child, financial needs, social needs, and other. And we categorized findings from each of these articles based on their themes, and then we identified sub-themes. So for one example, we had, our pre-identified theme of access to information, and a sub-theme that we learned was that families, even after getting information from their clinicians, there was a need for families to do their own research using online sources, patient advocacy foundations, and connecting with other families on social media groups. Next slide, please. Can you click it one more time? Oh, sorry. Keep going. I didn't realize there was, yeah, I think that's everything. Okay, thank you. So we conducted 3 focus groups for parents and patient advocates. And prior to these focus groups, we asked the parents to also complete a journey mapping activity. And this activity presented parents a series of sequential text boxes. And for each box, they were asked to describe a key event in their family's journey or their child's journey. And they provided details like the age of the child, what was challenging about the event and what made things worse, and also what made things better and what went well, and then what would have been an ideal outcome from that event. And following those, reviewing those journey mapping activities, we ultimately had 3 focus groups. So we had 14 participants total. The first 2 focus groups had parents, and the second focus group had patient advocates. The moderator guided the discussion using questions, again, from those pre-identified themes that we had identified in the literature review, and also what we had identified using the journey mapping activity. So these themes now were the access to information, access and use of high quality services, the ability to meet the needs of the child, financial needs and social supports. And after the first parent session, we also added additional themes, including quality of life and mental health of parents. All right, next slide, please. Sorry. There we go. Okay, so after our data gathering with our literature review, our regional genetic network outreach, and these focus groups, we revisited our team's development of the family outcome scale for early intervention. Don had mentioned this in the beginning, that our team had developed this specifically for early intervention. And despite our known differences between EI and newborn screening, this framework provided a starting point to map our themes into actual outcomes to be able to assess family outcomes. Next slide, please. So here are the current draft outcomes of newborn screening, and we'll reiterate that these are in the draft form. We've started soliciting feedback from these, and we're hoping to get feedback again today, and I'll read them out loud. So our outcome 1 is that families understand their child's diagnosis and treatment options. Outcome 2 is that families access high quality medical care, treatments, and services. Outcome 3 is that families navigate healthcare and service systems and advocate for their child. Outcome 4 is families manage the day-to-day needs of their child in the home environment. Outcome 5 is families maintain emotional well-being and have support systems. And outcome 6 is families achieve optimal family functioning. Next slide, please. And so I'm going to just pull out this first outcome as a specific example. So our outcome is that families should understand their child's diagnosis and treatment options. And below in the bullets are some specific examples of evidence that this outcome might be achieved. So families understand how the condition impacts their child's health and development now and over time. Families are able to evaluate conflicting, incomplete, and complex information. And families know specific next steps for treatment and care. And so now we're developing these types of examples for evidence for each of these draft outcomes. Next slide. And after we do some revisions on these outcomes, as Don also mentioned, our next step is to release this public survey to get overall feedback on all of these draft domains. And this survey will be online and will be intended for anyone that's involved or affected by newborn screening. And for each draft outcome, we will ask things about whether the participant thinks that it's how important they think it is to measure, whether they think the outcome is clearly written, and whether they have any ideas or concepts that are critical to be measured when assessing this outcome. And the last question will be asking if they think that we are missing any family outcomes or any domains that they don't think are reflected in this initial draft. And so we are hoping to have a survey that goes live over the next few weeks. So if you get an email from us, we hope you take this survey and also share it with your networks. Next slide, please. So wrapping up, I've identified our steps to how we got to this point and describe our efforts to develop a scale to assess family outcomes after newborn screening. We are going to now revise these outcomes based on the feedback that we've already gotten and also that we plan to get in the future. And then we will publish our findings and where we are to this point. All right, I have just the final slide to say thank you very much. And I think that Don and I are now available to answer any questions that you have.
Thanks, Elizabeth. I mean, I could just make a few final comments, Dr. Kalanj. In our last meeting, we made a distinction between outcomes and satisfaction. And we think this is an important distinction. Of course, it's very important for families to be satisfied with services, both during newborn screening with the program itself, but in subsequent treatment services, genetic counseling, and so forth. And so it's an important thing to document. The satisfaction is only one part of a broader understanding of what newborn screening means to families. And so what we're very interested in is specific outcomes. Now, you could say outcomes from newborn screening, outcomes after newborn screening, outcomes as a result of newborn screening. And it's hard to link them necessarily directly to newborn screening because so much happens right after the screening itself, especially if you wanted to use an instrument like this 2 or 3 years post-screening. So, a better title might be family outcomes for families who have had children identified through newborn screening. We want these to be very practical outcomes, functional things that actually could identify areas that might need strengthening in the follow-up support for children and for families. Also, we think it could help serve as a longitudinal tool to look at how families change over time and what factors might influence family change. So we're very excited about this work. These will not be items that a professional would sit down and rate a family on. These would be families' perceptions of their outcomes and their benefits. And so we're really very hopeful that ultimately we'll have a useful tool that could fill a variety of research and program improvement goals. So thanks very much. We're glad to answer any questions.
I appreciate it. And thanks to both of you for coming and sharing where you're at in the current project and promise what's to come. I know we are all looking forward to what we continue to learn from your work and the use of your tools moving forward into assessing the benefits associated with early detection and treatment. I'd like to open the meeting to comments and questions, starting with committee members, and then turning to our colleagues, our organizational reps. Jeff.
Thanks again for this presentation, and just to connect with the different things that have happened today. So, we started earlier today talking about the involvement of families and patients in research. And so one of the things, as Don mentioned, is that you could use this tool as an outcome in research, right, across a whole bunch of different conditions. We at HRSA are not very much into research. That's not our main mission, right? Although we have some projects like this with RTI, we are much more into making sure the system of care works for every single child. And so we support state newborn screening programs, not just to make sure that the conditions on the RUSP can actually be screened for, but we're now trying to turn toward, well, what happens afterwards? And as Don pointed out, this is not really just an outcome for families of newborn screening, but everything that happens afterwards, with the principle that it's no good to screen for something if a family's not able to get the treatment they need and the resources they need to get things done for their kids. So we're hoping that if this becomes part of the system of care, so we're measuring our healthcare system not just on whether a child had a well visit or they had a vaccine, which is commonly how we measure our healthcare system, but we also are looking at what really mattered to families, then we would be able to do a continuous quality improvement approach that really made sure that kids were thriving. So this is a critical set of works that Elizabeth and Don and their team are working on. And we really want to thank the committee for really driving this work early on. And I think it might have been Natasha Bonham who said, we really need to pay attention to what families need if we want to make sure the system is working right. So thank you all.
Thanks, Jeff. Ash?
Yes, thank you for the presentation on a very important aspect of the work. The question I had is, I think for outcomes on families can be viewed in possibly in two ways. One is whether there are answers or there are facilities that are available that the family has difficulty accessing, or perhaps there are system deficiencies which produce less than optimal outcome for families. I'm, for example, looking at the outcome 3, that families navigate healthcare and services systems and advocate for their child. Is that, so that may partly or quite a lot depend actually on whether the health system has built in certain features that like a navigator, a patient navigator for rare diseases, and where multi-specialty care can be coordinated in some way. So would your surveys allow for some of the distinctions so that could inform HRSA and how the health systems can improve?
Okay, yeah, I'll just speak to the difference between outcome 2 and outcome 3. And I think that's something that we've now heard from feedback from different groups. And so I think that we're envisioning outcome 2, which is families access high quality medical care. And that to me would include access to care coordination. So families have care coordination at the hospitals, and the care coordination is helping them do outcome number 3, which is the ability to navigate and access those services. But that is something that came up, I think, in almost all of our focus groups and in the presentations from our regional genetic networks, that families, even with care coordinations, families have to advocate for their kids to be seen at different specialist centers, and they have to kind of be able to work through the system. So I think that how we're seeing it right now, that it's important to keep both outcomes, but that is something that we might be able to merge or think about whether they should be merged for those 2 outcomes.
It's a really important question, Ash. Thank you very much. And it's a tricky distinction that we're trying to make here. It seems like it's a fine one to a certain extent, but it's important. So we're not going to be asking, are there systems of care available for families for a particular disorder, or specialized treatment centers. Because that's really that's the system. What we want to know is about the family themselves. So an example of flipping that around is that families are confident in their ability to find and access existing services. So it's not the fact, and then you can start asking questions like, well, if there are only 2, treatment centers in the country for one condition versus 20 for another condition, do you have different family outcomes in that set of circumstances? So that's a little bit of a distinction between what we're trying to accomplish here. It's hard sometimes to disentangle those things, but we've done it before, and so we'll be using lots of feedback mechanisms to help try to do that again. Hopefully that helps.
Natasha?
Hi, Natasha Bonham, Genetic Alliance. This builds on the conversation we're already having. Where do you see is the appropriate place, and maybe this has been informed by the work done in early intervention, to have that, I guess you could call it a critical look at the system. I think these outcomes are really good, and I worry that someone either intentionally or unintentionally would read the outcomes, and the onus and responsibility is on the families, when there are certain things that I'm looking at. I took a screenshot of the outcomes, what part of outcome 1, let's say, families understanding their child's diagnosis and treatment options, can we tie to the families, and what part of that do we tie to the system? And just if you could just speak a little bit more to how you see parsing that out, where that would live. Maybe that lives in a different phase of this project, or it lives in a different place. I think that would be helpful for me. Thanks.
Yeah, I think that it's a really important question, and I think it's also depends on either the research question or the purpose and the timing of when this tool is used. I think specific for, outcome 1 that you brought up, so families understanding, we had a really great pediatrician on our expert advisory panel, and she was saying that if she was reading the, families' responses, and that was, over and over, we were learning that the families were not getting the information that they needed from their doctors, and they were going to, the advocacy groups or Facebook groups to find out the information that they needed. Like, what can she do differently to support those families? So I think that we're hoping that it does not fall on the family to say, this is because, it is the responsibility of the family to understand the medical care and the treatment options within the first couple weeks of learning their diagnosis. But what can we do if if families are not understanding? Like, how can the pediatrician then say, okay, what can I do differently when we share that information back?
Yeah, and I just to add into that, I think, to me too, it's also hard to understand what success looks like. And maybe that is, success looks like XYZ, depending on if this is being used in a research context or being used in a different context. But, because even then sure, yes, a pediatrician should be able to help a family understand, but going to an advocacy group isn't necessarily a fail, right? There is success in that. And so where and how do we construct that? So we may not necessarily be saying, oh, that's a good outcome or a bad outcome. It's just, this is what's happening. This is the reality. How do we support the best possible, not to say satisfaction, so I don't want to say experience, but, the best possible outcomes for these families. So thanks.
Yeah, and just to further add to that, so, we don't see this tool as meeting every measurement need in the system. It fills a gap for where there's nothing available right now. But there'll certainly be tools to look at other people. There are existing tools to look at aspects of the system, how family-centered a program is, timeliness of things, et cetera. And this would be one way to look at whether those things make a difference ultimately in family outcomes. You raise an important point, is we don't want this to come across as in a way that families would feel judged, or that they would feel uncomfortable saying, I don't really know how access my child, the right kind of services for my child. So ideally, we would be doing that in a more sensitive one-on-one interview or discussion with families, but we're hoping to have a scale that would be used, an instrument that would be useful on a large scale. And so how this is presented, the introductions to it are going to be really important to make sure that, well, we want to find out information that would help us improve the system to better meet your needs. The only way we can do that is to have you provide this information for us.
This is Jeff. Maybe I can give a use case example to help Natasha and others see how this might be used. So you may remember a year or two ago, we had the Connecticut newborn screening folks present, and we'll have a follow-up. And they connected the newborn screening results to Connecticut Children's Hospital, and it gets built into the electronic health record that's basically used also at Yale. So there's two hospitals that take care of most of the kids. And so for things like sickle cell disease and hypothyroid and a few other conditions, they now have a population-based approach where they can look at every single child who's identified by newborn screening and those conditions and say which of them are meeting clinical guidelines. And they've demonstrated over a couple of years that by using that, not just at the individual level, but at the clinic level and at the statewide public health level, they've increased their adherence to clinical guidelines from about 60% to above 90%. Really extraordinary. So a great example of how the system's working. They are currently sort of sending out to families ahead of visits a thing that they put together that says, how are you doing? And what we're hoping is once the RTI team has developed a measure that's sort of been built up and based on research, that we'd be able to use that. And they would say, we would use that instead, say what is working well in the system and what isn't. And so it would be a continuous quality improvement approach, absolutely not to blame families, but to say, what is it we're doing that's working? What is it we're doing that's not working? And how do we make that better? So that's one of the ways we could see this being used in a system of care setting.
Thanks, Jeff. Amy?
Yeah, I just wanted to reiterate some of the comments, I think, especially some of the last comments from Dr. Bailey and some follow-up on Dr. Law's question, that we as, I think, the expert advisory committee really struggled with how to determine outcomes as a true result of the newborn screening process versus outcomes we see simply as a result of a healthcare system that's currently not set up to appropriately care for patients and families with rare diseases, no matter the modality of detection. And so I think this will be a continued important consideration as we think about things like outcomes and harms, understanding that dealing with a chronic condition, even when detected early, is still not easy. And there will remain issues with access and a trauma across the lifespan. And truly, until we fundamentally change our healthcare system, which is unlikely to happen anytime soon, I don't think we can or should expect that newborn screening will necessarily result in kind of the successful achievement of all of those outcomes. And so I'm wondering if we need to also be thinking about what a control group will look like. What should we be comparing to? Are we comparing to those who went through a diagnostic odyssey and had a clinical diagnosis? Are we comparing to those who have common complex diseases? Kind of what is our baseline that we would be comparing outcomes to in order to determine success?
Well, that's a really good question, Amy. I think part of me says that's really not what we're trying to do. We're trying to say we want to know where families are after newborn screening, because knowing that in and of itself will help us know whether and how to improve the system. It'll help us know whether we're being successful in a variety of aspects of what we're doing. And obviously, and you're right, there are going to be other things that we're not going to be tapping here, both characteristics of the system, but also some of the negative things that this committee has considered in the past, like parent anxiety, about uncertainty, families, stress in parenting, the stress in trying to find good services. So those are their tools available to measure those kinds of things. And what we're trying to do here is measure benefit, the positive things that could happen, and whether those benefits are achieved or not. And so, we'll leave it up to, we'll think about your question about a control group, but obviously there's not going to be any kind of randomly assigned control group. So there could be some historical groups that we could take a look at. You could look at a group of families. I'm sure Mike Hu would be able to give us some examples of families that have children with MPS who were identified late, and then families of children identified early, and examine some outcomes in each of those situations. It wouldn't really be a totally fair comparison, but there's interesting things that we could do like that.
Don, I'm just intrigued by the juxtaposition of this presentation and the promise of your work moving forward, and like the PCORI presentation, and just wondered how the tool and the assessment could be something they were aware of as they put together potential funding opportunities moving forward, especially in the rare disease and specifically newborn screening area. So I just see this kind of outcome is exactly what PCORI wants to focus on. And I don't know how to make that link other than to say, I hope you contact, the folks at PCORI and say, we want to make sure you're aware of the work we're doing.
Thanks, Ned. And we will distribute information widely. We're really hoping to get a peer-reviewed publication in a high-quality journal so that we'll have also a strong basis for sharing information. But you're right, some early descriptions of the activity and what we're trying to accomplish could actually, and getting that information out to a variety of sources could actually inform what we're doing as well. So thanks very much.
Appreciate it. And I really want to thank you both for coming and presenting. Elizabeth, it was great hearing from you, and Don, it's always good hearing from you as well. And we look forward to the next presentation, which I think will bring us further still. So thanks for coming. I know we've been going for a while. There's a break after the next session. So I hope folks can stick with us as we move into the next agenda item. You'll remember at our August meeting, we voted to move metachromatic leukodystrophy to the evidence-based review by our evidence review group. The ERG, or Evidence Review Group, is an external group that collects and reviews published evidence on a nominated condition. The information they review may or may not have been included in the nomination package, because the approach to this work is always to do a comprehensive literature search of all available published evidence on which to inform our decision. We'd like to have an update today. We're excited about that. And joining us for that update is Dr. Alex Kemper, the lead of the ERG, and the Division Chief of Primary Care Pediatrics at Nationwide Children's Hospital, Professor of Pediatrics at The Ohio State University College of Medicine. Dr. Kemper's research focuses on the delivery of preventive care services, including newborn screening. And since 2013, Dr. Kemper has also served as the Deputy Editor of Pediatrics. And, Alex, by the time I finish my tour of duty, I'll bet I'll be able to say that without reading it. Go ahead and take things over. Thanks.
Well, thank you very much. This is going to be a brief presentation today. The purpose is really twofold. One is just to update the committee on the status of the review, and also talk a little bit about metachromatic leukodystrophy. So it's at the next meeting where we will have a longer amount of time to talk about where we are in terms of the evidence review and present some of our modeling work in terms of what we would expect would happen if all newborns were screened for metachromatic leukodystrophy. And then it's at the meeting after that that the vote occurs. So again, the goal today is just to have a brief update meeting. Next slide, please, or presentation. Next slide, please. This is just a list of our evidence review group, the best darn evidence review group around. I'm really lucky to work with these dedicated individuals. Next slide, please. And then, of course, with each project, we convene a technical expert panel of individuals who are knowledgeable or who have lived experience as a family member with the condition. We've had our first formal technical expert panel meeting already. Not everyone was able to come to that, but we're continuing to have conversations with those individuals who were not able to attend that meeting. And of course, there are going to be many other technical expert panel meetings before the project is done. Next slide, please. So I do just want to briefly provide an overview of metachromatic leukodystrophy, mostly to level set with what we know about the condition. Next slide, please. So it's a lysosomal disorder that's associated with the deficiency of aerosulfatase A, or ARSA is the name of the enzyme. It leads to the accumulation of sulfatides, and that accumulation is negatively impacts myelin, leading to the neurologic findings associated with metachromatic leukodystrophy. It is a progressive neurologic disorder that can lead to death when it's untreated. Reports of the birth prevalence varies regionally, and some of this may also have to do with how case detection occurs, anywhere from about 0.16 per 100,000 live births upwards to 1.85 per 100,000 live births. And again, we're still gathering information and expect to have a more formal presentation of what we know about the birth prevalence at the next meeting. Next slide, please. As the committee knows, there are different phenotypes of metachromatic leukodystrophy, ranging from late infantile to the early juvenile, the late juvenile, and the adult phenotype. What I'd just like to highlight on this slide is that about 60% or so of the cases fall into the late infantile phenotype, and about 20% fall into the early juvenile phenotypes. And these are the most these individuals are the most severely affected with the condition, although clearly those with the late juvenile and the adult phenotype are negatively impacted by the condition. Next slide, please. In terms of the ARSA gene, there are over 1,100 variants of it described in ClinVar. What's interesting, and we're still diving into this, into the evidence, is that unlike some of the other conditions that we've looked at, there's more information about which ones are likely to be pathogenic or likely pathogenic, which of course is going to be important when it comes to issues of diagnosis and treatment. Next slide, please. The main targeted therapy for metachromatic leukodystrophy is gene therapy. Although it's true that the gene therapy was approved by the European Medicines Association in 2020 and the Food and Drug Administration in March of 2024, there's been a much longer history of evaluating individuals who've gotten this gene therapy, with the oldest individual now more than a decade out from treatment. I do want to dig into the treatment approach a little bit, because it's different than some of the other gene therapies that we've talked about. So first, what has to happen is that CD34 stem cells have to be harvested, have to be retrieved from the individual. And then there's a viral vector that's that encodes for the ARSA gene that needs to be inserted into these stem cells, a process that takes 6 or 8 weeks or so. And then while this is ongoing, the individual can undergo myeloablative conditioning, that is preparing the bone marrow for receiving back these stem cells by infusion. The gene therapy itself can be given as early as 9 to 12 months of age, and The reason that it takes a little bit before the gene therapy can be given is because you have to wait for the infant to be big enough to appropriately harvest to retrieve and modify the stem cells. So as far as we can tell, and again, we're still in the evidence review process, so I just want to be sort of cautious and not drill into too many details, but there probably been about 40 individuals who've gotten the gene therapy for metachromatic leukodystrophy, and I've told you that at least one subject is now somewhere over 12 years of age. Next slide, please. So the target of screening is really targeted to who is eligible for the gene therapy. So that includes the late infantile and early juvenile phenotypes. What's not a target of screening, because it's not currently an indication for the gene therapy, is the late onset phenotype, which is the late juvenile adult subtypes that I showed you on the previous slide. There is also another rare condition called sapacine B deficiency that leads to ARSA enzyme deficiency, but it's not targeted by the gene therapy, and it's not a target of screening. But in subsequent presentations, you may hear me talk a little bit about it, and I just want to put it out there again that it's not a target of screening. Next slide, please. So in terms of the approach to screening, next slide, there are really three tiers. So the first tier is measuring the sulfatides in the dried blood spot with liquid chromatography tandem mass spec. There are different sulfatides that can be measured. What I want to highlight is that if you use the C1610H sulfatide, it really dramatically reduces the number of false positives, especially when you tie that to the second tier, which is the ARSA enzyme activity. That can be done in the same dried blood spot. Between the C1610H and the ARSA enzyme activities, your false positive rate in terms of moving to the third tier, which is sequencing, is, from what we can tell, pretty close to zero. Again, we're still going through the evidence review process, but just to sort of give you the flavor. In terms of the ARSA enzyme activity test, there is a screening test available, but there's a lot of work that's going on right now to make it more available, both within newborn screening labs and in referral labs. Tier 3, again, I mentioned, was sequencing, and diagnosis is based on confirmation of the elevated sulfatides that can be done in whole blood or in urine, along with confirming low ARSA enzyme activity. And then in terms of the molecular analysis, looking at whether there are two severe pathogenic variants or a severe pathogenic variant and a pathogenic variant with some residual activity. Those things really put you into the category that would benefit from the gene therapy. I would like to point out that both with diagnosis and treatment, there are clinical care guidelines that are available. Next slide, please. So I just want to touch a little bit with where we are in terms of current activity. Next slide. So we had the first technical expert panel calls I talked about towards the end of October. We're continuing with key informant interviews. We've completed most of the first level review of articles, and there's something about 300 articles or so that are going to go to the next tier with more formal data abstraction. We've begun to think about the issues of modeling the impact of screening. We're looking for additional information, including from gene therapy clinical trial that's going on in Italy, and looking for, in addition to the published reports that we have, unpublished information about outcomes from others treated with gene therapy. There is some important screening activity that's going on right now. So in Germany, there's a recent report in the New England Journal of Medicine describing more than 100,000 newborns who were screened with 3 cases identified, including 2 with metachromatic leukodystrophy who went on to receive gene therapy. I have heard that there are another 2 infants that have been identified through that screening work, but again, we need to trust but verify, get the information on our own as well. There are lots of other pilot studies going on, including in Austria, in the UK, and of course, we're looking for other places within the United States. Screen Plus in New York has been active with screening for metachromatic leukodystrophy, and there are plans underway to transition that to the New York Newborn Screening Program. There's also some preliminary work going on in other states, including Illinois, Minnesota, and Tennessee, all in a much sort of earlier stage of things. And of course, there may be other newborn screening programs that are involved that we don't know about. And then one of the important areas that we're trying to understand and I don't want to get into it too much for the purposes of today because we're still gathering the data, but is around the availability of the second-tier HRSA enzyme test in the United States, either for the newborn screening programs themselves or as a send-out laboratory. This is an active area, and I suspect that when we present at the next advisory committee meeting, we'll have a lot more information about the status of things. So I don't want to sort of presume now about where things are going to be when we come again and meet, just because it's such a fast-moving area. Next slide, please. So let me just open it up for questions as well, in terms of if there are any questions about where we are now, particular areas that people want us to look into. I'm hesitant to dig too much into what we know about the benefits of early intervention or screening and those kinds of things, just because this is a work in progress.
I appreciate the update, Alex. Well, while it was an update, it was pretty dense with information, and we appreciate kind of hearing where you are and kind of where you're going. I wonder if there are any questions or comments, starting with members, especially, let's say, if there are any panel members that are participating on the review committee. If you're interested in making a statement or comment, that would be most welcome, but not necessary.
And I should say, we just, in terms of the liaisons, we were just informed I haven't reached out to them yet to rope them in, so I don't want to put anybody on the spot.
Yeah, so they won't be able to provide any too early. So I'll throw it open to the rest of the group. Alex, this is what happens when you say, don't ask any questions.
Don't ask any questions. Had I known that would work, I would have used that as a line on a regular basis.
All right. Thanks so much. It's exciting. It's an exciting review. We appreciate the work so far, and we're really looking forward to the final presentation, discussion, and hopefully eventually a vote. And as always, my thanks to the ERG and all the folks that work with you. And that brings us to our break. So why don't we stick with the concept of having a 15-minute break, and that would get us back here at looks like 2:25. Is that correct? Yeah, 2:25. We'll go ahead, and as long as our next speakers are available, we can get started early and go from there. So we'll see you in about 15 minutes. Thanks. people come back on, listening to Alex give his update on MLD, I just reminded that we are still working on DMD. We'll have more information for you in February, and that's all the update I have for you at this point in time. But I want you to know it's still in consideration and still in the works. It's not dropped off. We're continuing to work. So appreciate folks' patience and understanding, and the nominators who continue to work with HRSA staff and the evidence review group. Appreciate that work. At this point, we're going to turn to talking about laboratory developed tests. In October of 2023, the committee became aware of the final rule from the Food and Drug Administration related to laboratory tests, or LDTs, and we've heard from several public health laboratories throughout the country that the impact of the ruling will have significant impact on their ability to screen for conditions that are already on the RUSP and for future conditions that may be recommended to be added to the RUSP. We invited a representative from the Food and Drug Administration, Center for Devices and Radiologic Health, to present to the advisory committee on the final rule. They made us aware that there is pending litigation regarding the rule and that FDA does not comment on pending litigation and therefore could not participate in the meeting in that capacity. I will tell you that there is still the opportunity to provide comments on the final rule. If you look at LDTF final rule on your browser, it'll get you to the LDT final rule at fda.hhs.gov, where additional comments can be placed. So given that we don't have our friends from FDA joining us specifically to talk about this issue, we've invited Peter Kyriakopoulos from APHL to provide us with more information on the final rule and the phase-out policy for LDTs. And then following that presentation, we'll hear from Scott Schoen, who's our organizational representative for the Association of State and Territorial Health Officials, or ASTHO, who's going to talk about the impact of the final rule on state public health laboratories. By way of introduction, Peter Kyriakopoulos is the Chief Policy Officer and serves as a Principal Public Policy Advisor to the Executive Director and the Board of Directors of the Association of Public Health Laboratories. He's also a frequent consultant to senior CDC, HRSA, and FDA leadership on federal legislative and regulatory activities and issues. Scott Schoen is the Director of the North Carolina State Laboratory of Public Health. Prior to serving as the Director of North Carolina, Scott spent almost 10 years at the New Jersey Department of Health as the manager of the newborn screening laboratory. He's a member of the editorial board for the International Journal of Neonatal Screening. He's an organizational representative to our committee and representing ASTHO, and he's a president-elect for the Association of Public Health Laboratories. We're pleased to have both these experts with us today, although Scott had to be here. So, no, Scott, I'm kidding, thanks. And I'll turn things over, if I could, to Peter.
Thank you very much, Mr. Chair and members of the committee. I'm very happy to come back and talk in a little bit more detail than my August presentation. And you can see here on this slide my name and in the name of Amanda Kosser, who goes by Mandy, and does an awful lot of the thinking in this space for APHL. So the next slide. There we go. Is kind of a reminder of some things I've shared with committee already. APHL is perhaps the only laboratory organization that is not opposing the Food and Drug Administration's efforts in the area of lab developed tests. We are working very hard to develop and share useful information with FDA so that they can accomplish their tasks. And again, I would remind you that FDA, like HRSA, like CDC, is a federal partner for APHL and its member laboratories. The next slide is also a bit of a refresher, some of the actions that have occurred. And it includes links to some of the comments that we have made, not just on the final rule, but on the two draft guidance documents that FDA has put out. And the reason that I want to remind the committee about this is that we anticipate that there will be many more FDA guidance documents. And we are very interested in providing the information that FDA will find useful in the development of those guidance documents. We've already spoken about the fact that we believe newborn screening tests require an immediate health response because so many states now have state law that says you must begin to implement a new disorder as soon as it hits the recommended uniform screening panel. So that is an issue that we have presented to FDA and will continue to discuss with them. The next slide provides an update on some of the activities since we last spoke in August. Again, I think you've already seen we do have a position statement on the LDTs in general and also comments on the proposed rule. We have been collecting comments from APHL member laboratories who are working very hard to understand what they need to do to comply with the final rule. We have created a website, and you can follow that link and get to the information that we have found so far. And this is a very dynamic process for APHL. So we continue to get input from our members and try to describe try to define better the questions that we will be seeking guidance from FDA. And again, this is broad for all of public health activities, but also very precise on the newborn screening aspect of the public health laboratory work, because that is an area where we believe the final rule could have a significant impact. Our board of directors asked us to create a task force of APHL members who will be meeting on a regular basis and also getting information from our members, APHL laboratory members and federal partners to best understand how the final rule can impact public health laboratory operations and how we can share information with FDA. So the task force was approved. It has been formed. It has met a couple of times already, and we have a monthly schedule for them for the duration of our efforts to try to again try to both understand the impact and provide useful information to FDA. And again, the materials and the understandings, the learnings that develop from the task force activities will cycle back into our website, our web page on LDT resources, so that we can share it most broadly. The next slide gets to some of the actions that we are also providing. Our board of directors, we have regular monthly meetings of our board of directors, and we include updates to them on how the task force is going in the meetings and conversations that we are having. Again, we are in the process of developing templates for our member laboratories to use to come into compliance with the FDA final rule. Most of our laboratories really do not have this level of interaction with FDA, meaning they have not been in the process of even basically communicating much with FDA about laboratory developed tests. And so this is very, very new for just about all of them. And we are looking to provide materials that are going to make it easier, not only for them to understand, but for them to submit the information that FDA is going to find useful. You heard mention of the challenge that our federal partners at FDA have in directly commenting on the final rule because of the litigation. And for those who may not be aware, I'll just say that the litigation, the final documents that FDA will file in the court challenge to its authority to even pursue a rule on lab developed tests will be filed by FDA at the beginning of December. And there is, I think, some sense that after those final documents are filed at the beginning of December, that it will take some time, perhaps to the middle of summer, next summer, 2025, before there is an initial court decision. And the reason I'm using the word initial here is because I believe that initial court decision is likely to be mixed, meaning that it will find in favor of FDA in some instances and in favor of those challenging FDA in other instances. And then that will likely lead to additional litigation. So I think that this is going to be something that the court will be spending time on, courts, I should say, will be spending time on for quite a while is what I would say. So if I haven't emphasized it enough already, let me come back to the fact that newborn screening, as I'm guessing you've heard already, presents a unique challenge to the public health laboratories because so much of the work done for newborn screening is done using lab developed tests. And that is especially true when it comes to disorders that are added to the RUSP and then implemented by the state programs. I believe that APHL, we have discovered that it takes on average 2 to 3 years after a disorder has been added to the RUSP for an FDA cleared test to come into existence. And so that is a challenge that we are aware of and would want obviously to be able to screen using a lab developed test until a commercially available test might be developed. The next slide will have links to many of the things that you've heard me already talk about here. And if you just want a sort of a nice overview, I strongly recommend looking at the webinar that is listed under the second bullet there. There's also some FDA webinars that are all quite good on what the final rule looks like. There are links to the court, the challenges that have been filed in court by ACLA and by the Association for Molecular Pathology. And then there is a reference to the House Appropriations Report language. And the reason that we're including that reference and link is that the House Appropriations Report language specifies that the FDA will not implement the final rule. And the language itself is significant because it is language directing from a body of the Congress, the House, directing FDA to not implement. Some might observe that the language might have been stronger had it been bill language and not report language, and that the bill language would have specifically prohibited FDA from spending any money implementing the final rule. This is different. This is not that, but it is directive from Congress. So and it is included in the Agriculture Appropriations Bill, which is what funds FDA, unlike all of the rest of the Health and Human Services operating divisions. There has not been a resolution to the Agriculture Appropriations Bill or any other appropriations bill, for those of you who follow federal funding, for the current fiscal year that we, federal fiscal year 2025, which began October 1st. So what that means is it is unclear whether the report language in the House bill is something that will ultimately wind up in the final Agriculture Appropriations Bill report language. The Senate has no similar language. The Senate is silent on that issue. So we'll when we get to making decisions about funding for the remainder of federal fiscal year 25, we will learn about whether that report, the directive report language, will stand in the final version. And then on the next slide, here we go. So this is just a reminder. We have the email inbox, if you will, the ldtquestions@aphl.org. And you can again see my name and email address, and more importantly, Mandy Kosser's name and email address. And I go back to the chair to determine if we just flow right into Dr. Schoen.
Go ahead, Scott.
Okie dokie. All right. Well, thanks. Thank you to Ned for having me speak today. You know, Peter gave a great overview of sort of the background and history of it and what APHL is doing to facilitate the public health labs and our response to this. You know, a couple things before I go in. You know, there's already a lot of talk of what's going to change, where are we going to go. You know, Peter highlighted the House report. You know, nobody knows. And so the reality is that as particularly in my role as a public health laboratory director, I find it prudent and responsible to prepare for what we know is on the books right now and what is currently scheduled to impact our testing. And I'll focus on that. I'm also going to try to keep this a little higher level, not get too lab geeky on everybody, so that there's a little more level of understanding of what we're talking about. But I'm happy to go into as much detail and excruciating level of science, laboratory science, during the Q&A, if that's where you want to take me. So the next slide, please. As Ned mentioned, I'm an org rep from ASTO, but I am not representing them at this time on this talk. And I am the lab director from the state of North Carolina, but HHS is not specifically behind sort of my interpretation of where we're going, though they are supporting me in doing this as a lab director. So next slide, please. So real quick, I just wanted to highlight, what are we talking about here? And these are IVDs, or in vitro diagnostic tests. So what's an IVD test? That's any test that's done on a sample, such as blood, in this case, dried blood spots that have been taken from a human body, and they're used to detect diseases, conditions, help monitor someone's health overall. Basically, any test that's used in the process of treating or making a medical diagnosis, that is an IVD. And FDA regulates IVDs, and they have a risk-based classification system from low risk to high risk. And they are, and these tests and these IVDs are evaluated based on that risk assessment. Many, many tests in newborn screening are cleared by the FDA as IVDs. I didn't say approved. FDA doesn't approve tests. They clear them for use in a certain category. And that's a critical distinction, because we often hear the misappropriation of FDA approved. They don't, the federal agency isn't going to approve a test. So they clear it for use. For example, our tandem mass spectrometry kits, digital microfluidics for lysosomal storage disorders, our immunoassays for galactosemia and hypothyroidism are all examples of FDA-cleared tests that we use every day in newborn screening laboratories. Now, some people choose to use laboratory-developed tests. Next slide, please. And laboratory-developed tests are defined as IVDs, these in vitro diagnostics, that are intended for clinical use. So they are intended for use to diagnose or identify a condition in a human, right? There's surveillance testing. You know, I get a bunch of de-identified flu samples submitted to my lab every year to look for novel flu emerging. Those don't have patient identifiers. We don't use them to treat and prescribe Tamiflu. Those are not covered by this laboratory-developed test issue. We're talking about identifiable for diagnostic purposes. And somebody say, well, Scott, we're screening. We're not doing diagnosis. No. That's a screening test is still a diagnostic test because it leads to some type of medical outcome for a patient, in this case, a newborn. They go see another physician to have more testing done that does lead to a diagnosis. But there is an actual action on behalf of a human person for the outcome of this test. So it's intended for clinical use. And the LDT is typically designed, manufactured, and used within a single lab. So I have an LDT, say, for measles testing. The Maryland Department of Health lab might have a different LDT, but they've developed it and validated it in their lab for that specific purpose in their lab. Now, LDTs include those tests I just highlighted, which are developed and run within a lab, but also the FDA-cleared tests I just mentioned. If we modify them at all, they then become a laboratory-developed test and fall under this rule. So the most commonly known one that I'll talk about later is cystic fibrosis variants, the 139 Illumina test. It is FDA cleared for use in whole blood, but most newborn screening laboratories use it on dry blood spots. That has made that test an LDT, and we've had to validate it for use within our labs as a laboratory developed test. Okay, next slide, please. So why does anybody care about this? Well, forever, FDA has used enforcement discretion. That is where an agency can bypass the regulatory requirements because risk is low or the benefit to the public is high. In this case, FDA has historically used enforcement discretion for LDTs. They've allowed clinical laboratory directors such as me to have my staff perform a validation. I review it, I sign off on it, and we can use it and I monitor for quality process in my lab. So that has waived the requirements to register the test with the FDA, to report adverse events to the FDA, to label my test, to advertise it, to make it publicly available, its performance metrics, and also to subject it to good manufacturing practices. All of that has been waived, which is typical for an IVD for LDTs. But that's what's changing. Next slide. So the FDA has announced last year, as Peter said, that they will begin a 5-year phase out. Starting, the clock started May of this year, May of 24, the 5-year phase out began. And in that phase out policy, the final rule says that LDTs will now be regulated by FDA as an IVD. And that those of us who develop and use LDTs will have to follow all of the practices I just said that has historically been under enforcement discretion for our LDTs. And that's across the board. We're going to talk more about newborn screening, but this is infectious disease testing. This is blood lead testing. This is all of those laboratory developed tests where there's no FDA cleared test on the market, or where labs have intentionally chosen an LDT because it might be faster. It might be more efficient. It often is a heck of a lot cheaper. And so labs have often chosen LDTs for a number of reasons, okay? Not just because the test doesn't exist, which is a major issue in newborn screening for rare diseases, but also because an FDA cleared kit could cost $6,000 to run, say, 960 samples, whereas an LDT could cost maybe $1,000. And that is a huge money savings, particularly for a cash-strapped program like public health and public health newborn screening. Next slide, please. So the 5-year phase out looks like this. And it is based on the risk categories, but everybody has something to do in May of next year. So 6 months from now, less than 6 months, 5 months and 3 weeks, that we all who have LDTs have to register them and report them to FDA, okay? We have to let FDA know we have these LDTs and we're running them. We also have to have in place a quality management system that can receive complaints. So if anybody is tested with one of our LDTs and they want to file a complaint, we have to have a system in place to receive that complaint and then share that with FDA. And then you can see on my slide, over each subsequent May, there are more and more requirements as part of the phase out until May of 28. LDTs that didn't exist before May of 24 have to either go away and we have to switch to an FDA cleared method if it exists, or we have to submit it to FDA for pre-market review. FDA has already said that they anticipate that newborn screening tests will fall under moderate complexity, moderate risk, which is on the last slide. The high risks are going to be in November of 27. And so that's the issue, right? So if you had an LDT running before May of this year, you don't have to submit it for pre-market review, but you still have to submit to FDA that you're running it and have a quality management system to monitor it. And as Peter said, most of us, if not all of us, are running LDTs in newborn screening, much less across our public health laboratories. Next slide, please. So I'm going to finish by talking about what is like the quick impact on newborn screening, but what am I doing in North Carolina with my team to prepare for this? So most labs are running their SCID and SMA testing on a laboratory developed test. It's quick, cheap, and easy. It is a highly accurate and effective test. I mentioned cystic fibrosis variant detection, but also lots of us are running genetic tests for galactosemia and hemoglobinopathies. Those are all laboratory developed tests. And then many of us are running XALD tests that we have found to be more efficient than the FDA cleared test, okay? And so these are all tests that if we're already running, so be it. That's fine. We'd have to report them and monitor them. But it also means we can't change them, because if they change, they have to be revalidated and now part of the new regulatory process. And we've already talked about several of the new emerging tests. The new conditions that were just added to the RUSP, there's no FDA cleared test for these yet. MPS 2, GAMT. We talked about MLD today with Alex's presentation. And all of the conversation around genomic sequencing. There are only, I don't know the number, but there are far fewer FDA cleared genomic sequencing panels than there are, say, what the vision for newborn screening is in terms of genomic sequencing. And so where this field is going to be impacted by this rule. So what am I doing in North Carolina? Well, the first thing is, we began working on this a couple months ago. We pulled our team together because, as I said, I oversee the whole lab, not just newborn screening. So I have to worry about newborn screening a lot, but I have all of my other tests that are LDTs as well. And so we begin to assess the costs. What is the cost of doing this business moving forward? How much staff do I need to monitor the regulatory components of this? What is the paperwork burden that's going to have to be submitted to FDA? We have bi-weekly meetings to talk about all of this planning for getting ready just for May 2025. Right? The problem, as Peter highlighted, is that there's more questions than answers. FDA has been doing a great job of getting guidance out, but there's still webinars planned in advance of May 25 that will give us guidance for how do we comply with the May 25 deadline. So there are some challenges there. In addition, the quality management system requires software. So we have data modernization challenges. We have to be able to accept those complaints and feedback from the public. So we have new communication methods needed. And as I said, we probably need new staff just to shoulder the burden of this. And then moving forward, it's a case-by-case decision. Do we want to pursue an LDT, or do we want to hold off until an FDA cleared test comes along? And this runs head on with RUSP alignment legislation. North Carolina is a state that has a 3-year RUSP alignment rule. And so how does that balance out? Do I have to go to my legislature and say, we don't have an FDA cleared test to bring an LDT on, it's going to take this long, this much money, this many people? And how does that balance out with the populations we serve? And so those are all really huge challenges that we face right now in newborn screening and public health in general when it comes to this regulatory oversight. I will say, finally, that I'm a firm believer that quality management of LDTs is critical. I am not against quality oversight of laboratory developed tests. Right? We got here because there are some pretty awful LDTs out there that take advantage of very sick individuals in our population. And so there needs to be quality oversight of this. And the vision I've shared for North Carolina is sort of what I take as a middle of the road moderate approach. I have colleagues who are just going to ignore this, thinking it's either going to go away or we'll deal with it in 3 to 4 years when it actually becomes a major concern. I have colleagues who have decided to stop LDTs altogether because they don't have the resources, bandwidth, or really expertise to deal with it. And I'm lucky enough here in my state that I have enough staff and with regulatory experience that we can navigate this together and make sure that I am still balancing that load, that I am working towards bringing MPS2 and GAMPD online in a manner that I feel comfortable submitting to FDA when that time comes. But again, that isn't going to be the approach across the country. And so I think that we're going to have to recognize this, Dr. Kalanj, as we move forward. And that's my slides. I'm happy to answer any questions with Peter.
Thanks, Scott, and thanks, Peter. Very interesting, and I learned a lot, Scott, about what our lab should be doing to not stop screening for a number of conditions when the final rule is final. So that's been quite helpful. Let me open things up for questions, and I'm going to start with Janine.
First, my apologies. I had to step away, so I missed the very beginning of this conversation. But what is the problem this is trying to solve?
I will share my thoughts on why this change, right? So right now, any high complexity clinical laboratory, so with a CLIA certificate, can develop a test, and the lab director can say, this has the appropriate metrics and the appropriate characteristics to do what we say it does. Okay. And for someone like me, with high quality standards, and for the public health lab directors across this country with high quality standards, I don't view that to be the issue. The issue is when you have rare conditions, rare cancers, rare disorders that rely on a one-off, say, genetic test, or a one-off or a biomarker that isn't necessarily widely accepted as an indicator, yet markets that and sells that. There are concerns about that being available to widely for laboratory medicine. And so one could argue that this is a broad swipe approach at a more focused problem. However, the reality is that FDA and Congress have tried to get a handle on the lack of oversight of laboratory developed tests for quite a while. And this has culminated in what we have now, which is the final rule. There has been legislative efforts in the Senate historically that just didn't go anywhere. And then this is the second attempt at regulatory changes. And this one, has gone through. And so that's really, I think, underpinning that. Peter might have a different perspective from his policy role.
Thanks, Scott. So no, I think that's it. That there have been some pretty bad examples, and FDA was not able to act on them, and so now they're devising a way to stop those from happening in the future.
Ash?
So I think the not being a laboratory person per se, I think that I'm just wondering if the problem with complying with the new rule will be compounded by the fact that there are multiple analytical methods for the same diagnosis, for the same screening. And why, if that is the case, then why do multiple methods exist? And can the EPHO help to consolidate them in a way that it's easier for maybe one or a few methods to just be approved rather than in every state have to do it on their own?
So I just want to make sure I have the question correctly. Because I heard, why do we have multiple different types of tests for the same, to look for the same? Okay, well that is correct. That exists across laboratory diagnostics, right? There are different tests to look for. If I go, I'm in North Carolina. If I go to the UNC lab to have rubella test, and I go to the Duke lab to have a rubella test, and I go to Wake Med to have a rubella test, I'm going to have 3 different types of tests looking for the same pathogen. So that exists across the laboratory. And so what historically has been with FDA cleared tests is the idea is that by having the regulatory oversight, the federal agency has assured that the performance metrics of these tests are comparable, right? And so that no matter where you go, you have the same condition, you have the same answer. And that's the attempt here around laboratory developed tests, is to achieve that quality oversight of assuring that if you get your results one way or another, you're going to have the same thing. I will also say that we've learned, and I think CF is a good example, and I see Michelle has her hand up, so hopefully she agrees with this, is that some states have decided necessarily to expand their panel for variant detection based on their population. And so sometimes they are running a different test. I'm probably shot myself in the foot by going to a genetic test, particularly one that's currently under discussion at national guidance level. But expanding the variant panel in a state like New York versus other states that have, at least right now, decided not to expand beyond what's available, say on the Illumina 139 panel.
Carla?
Hi, thank you both for this really very helpful discussion. Mine is not a question as much as it is just a comment, just to let you guys know what CDC has been doing to really help, to try to parse out how we can help support our programs. Peter mentioned the task force that's been set up. We do have representatives on from CDC on that particular group, and are looking forward to working with APHL to identify resources and so on that can help newborn screening needs. So several months ago, when this was put out, members of our branch did engage in a number of different conversations across CDC, with our division, with our colleagues at FDA, to try to understand what could be done. What we are working on right now is assessing different kinds of CDC-wide and division-wide support to help with an integrated approach as well for compliance. We're looking, just as Peter had mentioned, evaluating sort of materials, templates, and so on that currently exist within various centers within CDC that cover things like design and development and validation and implementation process that are necessary for part of this FDA package to help with sort of a customized approach. So certainly we'll be working with APHL with that. Similarly with SOPs and so on from other parts of the agencies. One of the things that we've been thinking about for a while is that if it's needed, we're looking at leveraging or exploring compliant processes for packaging reagents, for dispensing, labeling, packaging, and so on, to help provide newborn screening laboratories with reagent handling that meet the quality system requirements. And certainly I think Ash was asking about a more harmonized approach. Scott was correct. You go to a different laboratory and you get a different method, because that's just how it's done. But we are going to be having conversations with the APHL QA/QC subcommittee to investigate ways that we might be able to standardize multiplex biomarker evaluation. Not a trivial task, but we are going to be having a heavier focus on that. And with respect to our reference materials at CDC, we're certainly looking at trying to understand how we can leverage our materials to be able to help with that as well. So I'll put my hand down. That's just what I wanted to comment on.
Very helpful information, Carla, and thanks for chiming in and adding more to this very complex issue. Michelle?
Hi, Michelle Kajana from the committee. I wanted to thank both Peter and Scott for their talks this afternoon, and I agree 100%. There's been a lot of hand-wringing about this in the community as a whole. It's been talked about in many different committee settings with APHL and others. And so I'm wondering if there's some sort of a mechanism to formally, from this committee, to let the Secretary of Health and Human Services know that this is a big concern of ours. It's a concern on service delivery within newborn screening, but also, as you heard from Scott, public health in general. And I think the rule at its core, while, I feel like obviously everyone wants to do quality work, we want to have a quality management system in place. But the rule itself is sort of in conflict to what the charge of this committee is and all the work that we do to add conditions to programs as quickly as possible and as soon as it goes through the entire evidence review. And since Scott opened the door, you know, the CF example, so we have recommendations from the CF Foundation that were out for comment from newborn screening, where they are saying to do the most comprehensive CF genome, you know, CFTR gene sequencing test out there. And there's no FDA cleared assay for that. And in fact, the FDA cleared assays that are available now just, you know, run into the wall when you're thinking about doing equitable screening. And so we have sort of this, we have this charge to do screening as equitably as possible. And then we also have this, you know, the two things are going to collide with each other because of diverse populations in the, you know, across the country, and it's particularly in my state. So I'm just wondering if there's a way we could write a letter. Do we have that power? Is there some mechanism outside of our usual charge of what we've been doing in the past?
Well, I don't think that there's anything in our charter or in our enabling statute that says we can't write a letter. I think letting the secretary, letting the FDA understand our concerns and the impact that even with the phase out rule, this rule will have on the practice of newborn screening in states across the country, I think is a very important thing to comment on and to provide our input on. And so, you know, Jeff, I think talking with Michael and the administrator about, you know, we would like to write a letter expressing our concerns about this rule is something I'd like to pursue and see if we couldn't do that.
I defer to Letitia as the DFO, but as I understand it, this committee has the ability to make recommendations to the HHS secretary. So if there are concerns, then it's appropriate to draft something and send it along for further consideration. Letitia?
Yes, that's correct.
Well, I wonder what process we should use. So maybe there's a smaller group of us that might be able to draft the letter. Letitia, do you think we have to vote on the letter? Or, I mean, we can't vote today, but we can get a general agreement, I think, from the committee that this is something we might pursue. But once we draft the letter, does that have to be approved by the entire committee in a formal meeting, or do you have other routes to get it moving a little quicker?
Yeah, it does not have to be approved via vote, but we can send it out to all of the committee members for them to review and get their feedback on, but it does not have to be any kind of formal vote. So
why not after this meeting, I'll start working on a draft that we can get out to the rest of the committee and take input and try to see if we can get our concerns as the advisory committee on heritable disorders and newborns and children in front of the folks making the decisions around this issue. Ash?
And I just wanted to get a little more concrete estimate of, is this going to be disruptive to the current conditions being screened? I think there's been a lot of emphasis on introducing new tests for the conditions that are currently going to be nominated and coming in the next few years.
Well, in our state, we'll have to stop screening for 3 RUSP conditions.
But we get a wider picture of that.
Yeah, and I think it varies, if I'm correct, Peter and Scott, kind of varies by laboratory.
So, in terms of existing conditions, Ash, is that if the laboratory doesn't have the resources to register their LDTs and monitor them as I described, then the only alternative is to stop running them. So, and that's really that's at the heart. That's really at the, I think the most critical piece of what I think you asked is that yes, it can stifle progress on the new conditions where an FDA cleared test doesn't exist. But there are tests we run now where there aren't. I mean, there are a handful, right? As I said, some labs have chosen to do an LDT because it is perhaps performs better. Honestly, that there are LDTs that do perform better than FDA cleared tests. And they're often, as I said, a lot cheaper. And so a lab will have to shift to an existing FDA cleared test off their LDT if it exists, or if it doesn't, and they can't do what's required as part of the phase out policy, the only option is to stop running it. And so that could mean, you know, if I couldn't do it in North Carolina, then that could mean I would have to stop doing GALT DNA testing. Now, I will say that, again, we started running this before May of this year. So any LDT that existed before May of this year is legacied from a pre-market review, but still has to be monitored. So there's still work. Like it's not trivial. And so there is a potential impact on existing tests if a laboratory, and we focus on public health labs because we're the first line of screening, but and I'm not in a position to talk about the diagnostic labs. They typically have more resources and could potentially do this, but I don't think we've heard from all of them. And particularly those who are only running it for us, are they going to maintain and monitor some of those second and third tier, higher tier testing that we're about to hear about, actually?
Yeah.
Can I say then, if
Oh, I'm
that
sorry. Go
is
ahead, Ash. Yeah.
so if that is indeed a real potential for disruption to current screening, then that is directly the committee's business. I think then we can get a little more handle on what the extent of the disruption is going to be, then I think the letter, I would fully support drafting a letter. Thank you.
Michelle?
Michelle Kajana. I think one of the other things that Scott sort of mentioned, but maybe he didn't say crystal clear is it's not even the FDA cleared test. Some labs are going to have to get new equipment to do the test. So it's not even the cost of going to the new assay. You may have to build equipment, get equipment, or find people that can run the new test. I mean, there's a lot of things that go into this. You don't just sort of buy it off the shelf and use it, especially because many of us have been doing these LDTs the same way for many years. It's much easier for us to add something to an LDT platform than an FDA. You can't alter them. So that's another concern.
Cindy?
Yeah, I was asked to also remind everyone about the fact that many of the confirmatory tests done to confirm newborn screening conditions are LDTs. So this is also going to have a large impact on that, and probably put a halt to some of the requirements in order to, confirm cases or not. So certainly concerns about that too.
Thanks. Susan?
Hi, Susan Tanksley, Association of Public Health Labs. And kind of to add to what Dr. Powell just mentioned, another concern in there is, so public health labs, there is an exemption from the fee for public health labs, at least for the registration or like the submission of them, but that's not true for reference labs, and that fee is pretty extraordinary. So it does have potential huge implications for reference labs who are primarily doing these diagnostic tests.
Debbie, are you holding up your hand?
I am. For some reason, I don't have a raised hand, but I just wanted to, kind of reiterate Cindy's concern, the confirmatory laboratory testing and the referral labs that are doing some of the confirmatory testing that's needed are very much doing laboratory developed tests, and that they're, and for the genetics community, as Cindy can attest to, it's a lot more than just newborn screening that we're talking about. I mean, we're talking about almost all the testing that's being done on the genetics diagnostic side as well. And so I think that there's a very huge concern regarding the possibility of not being able to do this testing anymore. And, for a lot of the conditions, luckily not necessarily newborn screening, there are only 1 or 2 labs in the country that are doing the testing at all. And so then that would, even add more difficulty onto that. And I just wanted to add on my sort of 2 cents to the clinical side of this.
As I listen, well, first Ash's question and then other people talk, and should we ask a little bit more broadly to document across a number of programs the impact? I don't believe, as I listen to Peter, it necessarily ask APHL to undertake that activity, but I do wonder if it's something that we should do to provide additional context to the breadth of the impact, because as I said, as different laboratory directors have spoken, it sounds like there will be variation in the impact for different programs, and it will impact. It sounds like it will impact lower resourced programs more than perhaps those better equipped programs.
I was waiting for Peter to unmute, but APHL on behalf of the public health labs has collected with Mandy Kosser a lot, probably not everything that you just asked for, Ned, but that exists. It's on the APHL website that Peter highlighted, but I'm sure that can be further summarized. And there are pages of specific examples from different public health labs on the differential impact that you highlighted. There's probably more to get, but there's a huge start, and that was actually submitted by APHL on behalf of us member laboratories to FDA during the comment period.
Okay. Thanks. Well, I don't want to reinvent the wheel.
Be happy to help you find those references.
Appreciate it, Peter. Thanks.
Of course, an option is the thing that FDA spent a lot of time looking at, the state of New York clinical laboratory evaluation program, and they like that a lot. So we should all just send our newborn screening samples to New York, and they can then be exempt from the FDA requirement.
Thanks. Well, I appreciate this. I appreciate the presentations. They were excellent. And thanks for sharing with us today, and for your time today. And I think we have a direction for the committee that we'll get moving on when this meeting is done. And look for that in your email. And we'll probably put a little note in there saying, please do this. Please do this in a timely manner so we can get our comments and our position in front of the decision makers as early as possible.
Thank you for having me.
Thank you. Well, we have one more presentation today. The HRSA NBS Excel program, as you know, is leading a couple of ad hoc topic groups for the ACHDNC. Back in August, we received an update from the condition naming and secondary condition work group, and today we'll be hearing from the higher tier screening ad hoc topic group. For that process, I'd like to introduce Sean Maloney, who is the manager for Michigan's Newborn Screening Laboratory since 2022. She oversees the activities of the Newborn Screening Laboratory, including quality assurance, efficiency testing programs, and reporting presumptive positives to the follow-up section. She is currently pursuing her DRPH in public health and Clinical Laboratory Science and Practice at the University of South Florida. Sean Maloney served as the chair for this ad hoc topic group, and we're really thrilled to have you present to us today. Welcome, Sean.
Thank you. That is not the right presentation.
Yeah, it doesn't look like the right presentation.
No, I'm not talking about whole genome sequencing, though. Fascinating topic, but not today. Thank you very much. Good afternoon, and I appreciate the opportunity to give this committee an update on the higher tier testing workgroup activities. Next slide. Today, I will be presenting background on the higher tier testing workgroup, an overview of the in-person meeting, the 2024 higher tier testing survey results, the potential solutions and resources to identified barriers, next steps, future activities, and priority conditions. Priority conditions are RUSP conditions, which the newborn screening programs thought higher tier testing was most needed. Next slide, please. The higher tier workgroup is an ad hoc workgroup under the New Steps, New Disorders subcommittee. The workgroup was charged with proposing model practices to build a higher tier testing cross-program model of collaboration, to identify and discuss considerations to implementing higher tier testing in-house or through outsourcing, and if barriers to higher tier testing differed between new and legacy RUSP conditions. Before we could begin work, we agreed on the definition we would use for the term higher tier testing, which is laboratory tests performed subsequent to initial test results using the same dried blood spot specimen for the purpose of further identifying significant information that improves or enhances the interpretation of the first tier results. These laboratory tests examine different analytes or employ different methodologies than the first tier assay. Our next step was to develop a survey and to send to state and territory newborn screening programs. Once we had the survey results, we held an in-person meeting to review them. Next slide, please. The work group met in person this past July. We reviewed the survey responses, discussed facilitators and barriers to higher tier testing, started work on determining mechanisms to implement higher tier testing for new and existing conditions, and had presentations on various higher tier practices from state programs and partners. Next slide, please. We also discussed talking points regarding the importance of higher tier testing, reviewed conditions requiring higher tier testing and different testing options available, reviewed program reported survey responses about facilitators and barriers to higher tier testing. We began discussions of potential solutions and resources for barriers, and we began prioritization of conditions needing higher tier testing. Next slide, please. Next, I'm going to talk about the 2024 higher tier testing survey and responses. Next slide, please. Overall, we had 30 newborn screening programs respond out of the 53 programs the survey was sent to. For question number 1, we asked, is your program interested in adding or expanding higher tier testing to your newborn screening algorithms? 80% said yes, 20% said no. Next slide, please. We asked the programs to explain their yes or no responses. For those that said yes, they were interested in expanding tier testing, there were some common themes. For LSDs, there was a lot of focus on MPS 1 and MPS 2. Other responses were to reduce false positives and improve positive predictive value, update or expand cystic fibrosis second-tier screening methods, add second-tier screening for XALD, bring higher tier testing in-house, and higher tier testing is already a routine practice. For those programs that said no, concerns were raised about how higher tier tests were typically laboratory developed tests, and with the FDA's new rule, they were not certain of the benefit to bring them in-house. They're not cost effective for low volume states, and no expansion is planned as all higher tier testing is performed by outside laboratories. Next slide, please. We did use skip logic in this survey, so those who answered yes to question 1 also answered question 2, which was, if your program is interested in adding higher tier testing, what are the 3 main barriers preventing or delaying its implementation? The top selections were limited staffing, lack of FDA kit availability, lack of expertise, and limited funding. Next slide, please. All programs were given the opportunity to respond to this question. Does your program conduct higher tier testing in-house or outsource testing to another laboratory? In-house only, 10%, outsource only, 38%, and both was 52%. Next slide, please. Question 4 was, would your newborn screening program be willing to conduct higher tier testing for other newborn screening programs? Yes, temporarily was 50%. Yes, routinely 39%. No was 11%. We did ask for clarification on the no responses, and for those that answered, the reasons given were it would depend on the sample load and currently not in a position to test for others. Next slide, please. The next few questions will focus on in-house higher tier testing. Question 5 was, what are the 3 main facilitators that helped your newborn screening program conduct higher tier testing in-house? The top selections were technical assistance from other newborn screening programs, experts, or training, program administration and advisory committee support, additional staffing expertise, clinical specialist requests and support, and enhanced infrastructure. Next slide, please. Question 6 was, what are the 3 main challenges that your program encountered in the last year conducting higher tier testing in-house? The top selections were staffing limitations, limited staff expertise, and funding limitations. Next slide, please. Question 7, what are the strategies and solutions your newborn screening program used to overcome these challenges to in-house higher tier testing? Grant opportunities was mentioned a handful of times, facilities management exemptions, core lab concept for sequencing, technical assistance from other state experts, significant support from clinicians and advisory committees, stakeholders requesting legislation, batch samples such as for CF or XALD, staff to receive vendor training on new instruments to become subject matter experts, and hiring subject matter experts. Next slide, please. Question 8 was, are there any policies or regulations that prohibit your newborn screening program from outsourcing higher tier testing to another newborn screening program or private laboratory if tier testing cannot be implemented in-house for certain conditions? 83% said no, 17% said yes, 2 programs said yes, but only 1 specified a reason, stating contract negotiations are prohibitive on both sides. Next slide, please. Question number 9 was, what are the 3 main challenges that your program has encountered in the last year outsourcing higher tier testing to another newborn screening program or a private laboratory? Those top selections were contracts and agreements, turnaround time, and insufficient dried blood spots. Next slide, please. Question 10, what are your suggestions or recommendations for overcoming these challenges to outsourcing higher tier testing? Participants' responses were more national standardization and harmonization of screening panels, work with administration to show the benefit of second-tier screening, establish a central state laboratory, as MOUs with other state agencies are easier to establish than contract with commercial entities, assistance regarding future LDTs, make quality improvements to reduce the turnaround time to help offset the additional time for second-tier testing, have a single location set up contracts and pay for the testing, routinely applying for grant opportunities. Next slide, please. Question 11 is, how have you identified any gaps that need to be addressed before your program implements higher tier testing for additional conditions? Some of the responses were recruitment and retention, infrastructure, time-consuming procurement process, the FDA rule for LDTs, ensure leadership understands the value of second-tier testing, subject matter experts, laboratory information management system limitations, the interpretation of results, variance of uncertain significance, standardization of information, and knowing what higher tier testing is available. Next slide, please. Question 12 is, what additional support or resources would be helpful in overcoming the gaps and challenges to initiating higher tier testing, whether in-house or outsourcing? Those top responses were FDA kit availability, technical assistance and training, quality assurance materials and specimens, development of standardized protocols and guidelines. Next slide, please. Question 13 was, please let us know which conditions you feel are most important for your program to add higher tier testing for in the next 5 years. This is a list of over 20 disorders that the newborn screening programs mentioned in the survey. As a work group, to focus our initial efforts, we needed to come up with a manageable list of conditions. The work group decided the priority disorders, which are on the left side of the slide and have an asterisk next to them. They are all RUSP conditions, which the newborn screening programs thought higher tier testing was most needed. Next slide, please. Now I'm going to discuss the potential solutions, resources to identify barriers, and action items or next steps. Next slide, please. The discussion of the in-person meeting then shifted to potential solutions to barriers which are hindering the implementation of higher tier testing. Highlights of that discussion are assistance with contracting and procurement issues, a cost assessment study and develop a cost model, one center of excellence is not enough, training, normalize sending out while simultaneously building capacity in-house, networking, and piloting to determine the best approach. Next slide, please. The action items and next steps are produce a cost study, cost model for programs to use, policy statement and talking points resources, prioritize diseases needing tiered testing from those where tiered testing is just nice to have, provide guidance to programs to assess when tiered testing is needed versus cutoff changes or addition of ratios is needed, develop resources for programs such as higher tier algorithms, a list of what higher tier testing is available, and higher tier testing resource toolkit. Next slide, please. And here's a list of the higher tier work group members. And I would like to thank everyone who has given and continues to give their time and expertise to the higher tier testing work group. Thank you.
John, thanks so much. That was just a great presentation. And I want to congratulate and thank the working group for doing such great work. I think you provided a very pithy and condensed version on what I know was a great deal of activity and wrangling and discussion. So thanks so much to everyone who participated. I'd like to open the floor for questions for Sean and any other members of the work group who might be in attendance. Cindy.
Hi, Cindy Powell, ACMG org rep. I don't have a question, but a comment to just, thank Sean and thank the group for tackling this. It's something as a clinician that's really bothered me over the years, as new conditions are brought on, and if the public health lab is not doing all the testing, it's put onto their standard clinical care. And I've had experiences with patients who have been coming in to our clinic for confirmatory testing, and they get to the door, they get to check in, and they're told, well, we don't accept your insurance company. If you want to have your child seen here, you're going to have to pay often hundreds of dollars out of pocket. And, since we're the main center that they would be coming to for the testing, it really puts them in a very difficult situation. So I'd especially like everyone to think about the families and what we're doing to them in situations like this. So as much as the newborn screening labs are able to do, I think this is a great situation for regionalization of at least, this higher tier testing. So thank you.
Thank you. Carla?
So we really appreciate this this work group for putting this together and really parsing through the details of this. And again, we want to just acknowledge that CDC has been actively involved in creating methods and second-tier tests and working towards expanding our quality assurance programs to ensure that these biomarkers are not just, we don't just have tests for them that are multiplexed, but we also are creating reference materials for both PT and quality control, as well as linearity methods. And these are active areas of expansion within our program to help support the newborn screening needs as identified. And most of the conditions that have been identified are ones that we have ranked as high priority programs for providing materials for. They also include, again, the expansion for the CRF variants, which we're working to create materials for as well. And we acknowledge that one center of excellence is not enough. I just want to respond to that. We get that, but we are certainly hoping to be able to have additional programs. And just to let those who don't know that we do have workshops and technical assistance opportunities where states can call us up and ask for some of our PhD level scientists to come and help implement conditions and implement methods within their programs. It would be more ideal for them to have these positions themselves, but certainly the states can request these activities as needed. So we just want to let you know that we are looking at these as well, and we are very, very interested in also being supportive of these efforts as we move forward for being able to address these issues.
Amy?
Yes, thank you, Amy Gaviglio, or GREP, NSGC, and I want to build a bit off of what Dr. Powell mentioned, in that I think it is helpful for the committee to recognize the benefit of tiered testing, not just in laboratory performance, but truly in family experience, and in not just kind of focusing on the quantity of the diseases we screen for, but for the quality of that screening as well. And so I guess my question, also kind of as a member of this work group, is how to take it to the next level, and whether it is within the purview of the committee to make recommendations for programs to employ this level of testing for certain diseases. It seems like there may be some precedent for this, both in terms of, recommending acetone for tyrosinemia type 1, psychosine for Krabbe, but I'm wondering if that's something that the committee would be willing to look at, as it seems like a recommendation from the committee might help in overcoming some of the barriers that programs have discussed in terms of justification of adding this type of testing to their algorithm.
Thanks, Amy. And you kind of were moving in the direction I was moving a little bit differently, though. It's like, this is great work, and I think provided to the state laboratories can be quite useful. But then the question I was going to ask was, what could the committee do that would help with this process or move things along? And if we were to make recommendations around the issue, who would we be recommending to? And that's something that Jeff and Letitia and other HRSA staff and I probably need to talk a little bit about, but I think we'd like to capitalize on this information and move it forward in a way that will be useful for the laboratories and for diagnostic and screening and diagnostic testing.
Ned, if I could add to that, because there are multiple ways that HRSA supports state labs, and I guess I'd like to hear a little bit more, particularly from the lab directors, from Christine and Michelle and Scott and so on, about what would be useful. Because on one hand, we don't think that we want the federal government, or maybe this committee and its advice, either HRSA or the committee, to be saying, oh, you should do this, you should do that, you should do everything else, because that's really their expertise. And just to clarify, I think Krabbe, where it was a higher tier, that was to clearly distinguish what condition was meeting criteria. But it wasn't so much, we think you should, practice your lab stuff this way. So I'd love to hear from the lab directors what they would find most useful, either from HRSA or from the advisory committee.
Christine?
Yeah, I think from the standpoint of being here in the newborn screening laboratory, many times to move ahead with something as far as a second tier assay, you need that little boost or support from laboratory administration to move ahead with adding a second tier test, because it does cost money, and the purse strings are held by a higher authority than that person there in the laboratory. And oftentimes, and I'm not calling anyone out, definitely not the case in Maryland, but sometimes you don't have the support of your laboratory administration to move forward with a second tier or higher tier assay, for the very reason how newborn screening is defined as a screening assay. And when you get into second tier or higher tier testing, some of it can be basically diagnostic. When you think about SMN2 copy numbers, some of the DNA assays that are used with the CFTR, you have 2 delta F508 mutations on your CFTR 39 or 60 mutation panels. It's almost diagnostic. And so there can be some, I guess, help from putting out a statement or something of that nature that says, you know, second tier assays can improve positive predictive values. It can help with the specificity of assays, because it's a big problem. You're flooding the follow-up world with false positives. And the sheer amount of dollars that go into following up a kid just to eliminate that they don't have a disease could have been nipped in the bud from the very beginning. So yeah, that's my 2 cents.
Well, I appreciate that, Christine. I also think for the families, it's a better solution than saying there may be a problem. And in order to figure that out, we have to refer you to a specialist for further testing. So I think, you know, if those are answers that can be addressed at the laboratory level before the parents are ever called, there's huge value, I think, and harm reduction in that. So I appreciate your comment. Michelle?
I'll agree with Christine. I mean, I'll go old school. Having something in your hand, a piece of paper that allows you to go to someone and say, this is what the professional recommendation is helpful. It doesn't necessarily solve it a lot of the times, but it's still, I think, helpful and certainly can't hurt. Another thing that people pay attention to is overall cost, right? So in New York State, we were referring a lot of babies with one variant in the CFTR gene because we knew we weren't detecting them because of the diversity of the population, and the panels were geared towards Caucasian white families that had CF, because that's where the body of knowledge was when those tests were developed. And so we used the rationalization that we would save costs downstream and parent anxiety by going next gen, because that's more expensive, certainly, but we were able to sort of balance that out in the costs. And I'll just remind us that we're in the process of looking at MLD, and the recommendation is multi-tier testing. And so I think this is going to become more norm. And we know that there's a lot of work going on in homocystinuria and some of these other conditions right now to make our tests better by doing second tier testing or different analytes. And so I think it's an evolving landscape, but it's certainly something that it can't hurt to have something official from this committee. Thank you.
Thanks. Susan?
Hi, Susan Tanksley, Association of Public Health Laboratories. In my state, in Texas, we've always tried to take the approach of what is the additional testing that can be done to put out better results, fewer false positives, what's going to be the least impact. But it has always been a challenge to calculate system costs, right? So we talk about newborn screening as a system, but it's literally impossible to calculate all the costs and all the cost savings that are downstream. And those costs are to our laboratory. They are not, there's a whole system cost, but our costs are to the lab and the cost savings are downstream. And so that's a hard part on the budget of labs. So we can save money downstream if we put the money up front. And so that's where perhaps grants could assist in development of those second tier tests. But I do this ties into our last presentation on LDTs as well, because I don't know if we have a second tier test that is not a lab developed test. And as we add more conditions, our intent is to add second tier and third tier tests, all of which will be lab developed tests, all of which will be subject to those regulations. And so there is that direct tie-in as well. Thank you.
Yeah, I knew someone was going to point that out. Susan, thanks. Well, this is great input. And Jeff, I think maybe we should circle back both at HRSA and then with our colleagues at CDC and talk about, what kind of product statement or recommendation and to whom falls within the purview of this committee and those agencies. And Carla, I'm pulling in CDC because I know you're involved directly in this activity as well. And I think if there were a way to do a joint or a position or recommendation, it could be very powerful coming from two agencies.
Sounds good.
Any other comment on this particular issue? But that's great. I think we're a bit over time, but I want to move in and to allow a little bit of time for new business. I have notes that we have new business subjects from Melissa Parisi and Carla Colbert. And Melissa, are you with us? And you want to talk a little bit about the NBS Genome Project?
Certainly. Thank you for an opportunity to present kind of a brand new initiative to this group and to let you all know about one of the projects that NIH has just started embarking upon that I didn't actually include in my summary of currently ongoing research programs. Hang on just a second. So this is a newborn screening by whole genome sequencing effort. It's being led by the NCATS Institute, which I talked to you a little bit earlier about, and NICHD and NHGRI are also providing input into this new initiative. Next slide. This is something that's under the auspices of what we call the Common Fund. And these are initiatives that involve multiple institutes across NIH. They try to really garner opportunities that may exist and do rather bold things with modest amounts of funding. And this is a new venture initiative, which was just launched in 2024 and is funding a couple of other projects as well. So this is the third one selected under this new mechanism of venture funding. So the goal here is to demonstrate that newborn sequencing could be added into the newborn screening paradigm, and by basically testing the feasibility of adding whole genome sequencing into some state screening programs. The goal is to invest $5 million per year for the next 3 years. This is, and I want to really emphasize this is a consented research study. We are not proposing that all states drop everything and start sequencing. And the goal here is really to provide more equitable access to whole genome sequencing and keep pace with some of the therapeutic opportunities for treating rare diseases that are being developed and are continuing to come down the pike. Next slide. So this is really a collaborative effort, and it's a model whereby we would like to roll out a newborn sequencing program across 5 to 10 states with different capacities for actually adding sequencing into their workflows. We anticipate that this would include a centralized laboratory for analysis and interpretation of genomic sequencing results. We would focus only on a limited panel of genes that are associated with serious or life-threatening rare diseases that have early treatment options available. So we are not proposing sequencing and giving back reams of data, including variants of uncertain significance. It would be a very carefully curated set of genes that are actionable. We would hope that this could achieve equitable access to genomic sequencing in the newborn period by trying to do it on at least somewhat of a limited population basis. And very importantly, as I mentioned earlier today, we really want to include the ethical, legal, and social implications of this type of research program in a state newborn screening system. Next slide. And to that end, especially with regard to the ELSI component, we anticipate that this will establish a community advisory board or boards where we would really take input from a wide variety of stakeholders, including parents, including newborn screening programs, including clinicians, many other perspectives about that have relevance for this particular program, and that will have opinions about how this is impacting them and whether this is a good thing to do or this is not a good thing to do. So we anticipate that this input would include ways in which we can engage the community, a strategy for informed consent, approaches to data sharing issues, which are not insignificant, design of the research project, as we talked about earlier today, and how we could actually return results in a fair and equitable and valuable way for families and for providers. We hope that this might bring new expertise to the newborn screening field, and we also will try to anticipate and engage diverse perspectives, including those that are screened and those that are involved in the research project. And I think I have one more slide that is a bit of an overview. So this has not been launched yet. I mean, we basically got approval for this initiative in September, so this is really in its early infancy, but this is a potential structure for the program and how we might envision that it would work. And you see on the left, we have a community advisory board that would be giving input into the administrative functions, in which that would include the oversight of the program, consenting, development of a disease and gene list, data storage issues, etc. The community advisory board would also be giving input into activities related to participant recruitment and consent, as well as confirmatory testing and return of results. And that blue box then would interface with families, with newborns, with providers in the neonatal period. Off to the lower right, we would envision that state public health laboratories, after consent had been obtained, would be sending those blood spot punches for sequencing analysis, and then we would complete the cycle with, again, confirming results and return of results. So this is a very high-level view. We're hoping to launch this within the next year in terms of at least putting the solicitation out by the end of this calendar year and making an award by spring or summer of 2025, and then probably a year's worth of preparatory work prior to actually launching the sequencing per se. So that's what we're looking at. We've got 3 years to do it, and we really welcome feedback from the community. We were really grateful that at the APHL Newborn Screening Symposium, we had an opportunity to present this at a town hall meeting. Dr. Dominique Pichard from the Office of Rare Diseases Research at NCATS and myself, and we got a lot of really valuable feedback, both positive and negative and ambivalent, and we look forward to hearing more from the community about this initiative as we move forward. So thank you for the time to present that.
Yeah, thanks. And hopefully you'll make, the slides will be available, and individual panel members and organizational reps can have the opportunity to send you comments and notes of what their opinions based on your presentation today. Thank you.
Absolutely. Thank you.
Carla, you have a CDC update on ConPlan?
Sure. So the CDC, together with APHL and HRSA, and with input from state departments of health, we've recently revised the National Contingency Plan, or the ConPlan, for newborn screening. And this plan is designed to help states and regions and groups of states to maintain important newborn screening operations during public health emergencies. And version 3 of the ConPlan is the second update of the plan, and it provides more details about the different partners that are involved in newborn screening systems and their responsibilities. It also explains how Emergency Management Assistance Compact, or the EMAC system could be helpful, and it includes extra information to guide state programs onto what to do before and after a newborn screening emergency occurs. So the con plan has been signed by both CDC and HRSA, by Dr. Ari Bernstein at the CDC and Dr. Michael Warren for HRSA. And CDC has already begun to work to finalize the formatting of the document so that it could be accessed online. We plan to work with APHL to present a webinar early in 2025 to help states learn how to effectively use the con plan in their own preparedness and response activities. And we look forward again to having this document be out and available for the newborn screening community. Thank you.
Thanks, Carla. And I just want to add a final comment that Janine Cody had asked a question about talking about recommendations from the committee that could impact screening and care at points other than newborn screening. And this is a topic we talk about, seems like frequently. And what I wanted to tell Janine was that something we should kind of intentionally think about if we can craft some additional time at the February meeting to talk about planning about recommendations to impact care at places other than the newborn nursery. So I appreciate your interest, Janine. It's a real interest of mine. And Jeff and I have talked about it a fair amount of time as well. So it's time to think about it. Should we move forward a little bit more formally about the same kind of ad hoc topic work group approach or other strategies to kind of explore it a little bit further. So I wanted to make sure you knew I heard you and we heard you, and we'll in the interest of ending today, say let's put it off until February if that's okay.
Fine, thank you. I didn't know if it was just a topic I didn't know anything about, or if it was a general topic that could be clarified for the entire committee.
Oh, I think it is. And Janine posed a group of questions, all of which have answers, not all of which have satisfactory answers. But I think it's a great topic. And again, one that it gets back to that issue of what else is the committee charged with, where heritable disorders of newborn and children. And trying to make sure that we adopt the full range of the possible intervention and screening points is real important. So I appreciate that. Let's see, anything else for the good of the order today? We've run through our agenda. Remember that February 13th and 14th are our next meeting with the 20th anniversary. I suppose you could still make Valentine's Day plans if you need to, but we'll be spending at least part of that day together. And I look forward to seeing you all in Rockville next year. Now, that being said, we will continue to work. We have a number of agenda items and things we've identified today that we need to work on between now and the next meeting. You've heard that there are 2 and potentially more preliminary nominations that are being considered that we're working with. There's a ERG report on MLD. And then, as I said, we continue to talk with the nominators regarding DMD. So even though it seems like there's few months, they'll be busy months. And so I hope everyone has a great holiday season, and if we don't talk to you before, we'll be sure to be talking to you in 2025. Leticia, am I forgetting anything before we adjourn?
Well, you covered everything. Thank you.
All right, we'll see you all soon. Bye.
Bye-bye.